Good morning. Hello, ladies. How are you? All right. Took me a minute. My Zoom didn't want to work, but I got everything up and running for us to do our class this morning. So today we're going to do a little lecture, chapter 7, 8, and 9. All right. We're going to start with chapter 7. Ooh, my Zoom froze. Let's see. It's going to work for me. Yep. Okay. I'm moving. Okay, so how my Zoom meetings work, I'm going to share the slides with you and go over them with you. So let me just share. Okay, all right. There they are. All right, so chapter 7 is going to be safety and body mechanics. As always with our chapters, we first go over vocabulary words. Oh, sorry about that. They disappeared. Here we go. My computer's having some issues today. Oh, my slides are not working. There we go. Okay, so beginning of our vocabulary words, aspiration. This is going to be the inhalation of food, fluid, or foreign materials into the lungs. Very important in long-term care. We always have a nurse in the dining room because of the risk for aspiration. And the dining rooms always keep a suction machine. So if we have somebody that potentially is choking, is at risk for aspiration, we can provide suction as the nurse to try and relieve that blockage. Big worry about aspiration is any food, foreign subject, foreign material, or fluid that gets in the lungs, it has nowhere to go, right? If you can't cough it up. So a lot of times when an individual aspirates, it can lead to pneumonia. Atrophy. Remember, when we were doing occupied bed, I said the two reasons that we reposition people every 2 hours when they're bedbound is to prevent two separate conditions, atrophy and contractures. Atrophy is going to be the weakening or wasting away of muscles. Body mechanics. This is the way the parts of the body work together when a person moves. It's very important in this profession that you're aware of your body mechanics, right? Especially for my students that are taller, right? A lot of the times you do some procedures that are to assist. The other person you're working with might be a lot shorter than you. So, what's going to be a workable height to the bed? You're going to have to come up with a compromise, right? So, if you're taller, you might have to get a little lower to the ground. So, very important, you have a nice wide stance, low center of gravity, that you're bending with your knees. Always make sure your knees are bent, all right, and your back is straight. Very, very important because the two reasons I see people leave healthcare as CNAs is one, caregiver burnout, and two, they hurt themselves due to poor body mechanics. A chemical restraint, this is going to be medications used to control a person's mood or behavior. We have to be very, very careful when we are administering psychotropic psychiatric medication because we want to make sure it's giving a therapeutic effect. We don't want to be using it as a chemical restraint. So combustion, the process of burning. Contracture. So this is the other risk factor for our bedbound residents. It is the permanent and painful shortening of a muscle, tendon, or ligament. It restricts movement. So, for instance, you might have an individual with a contracture on their left arm. They're not going to be able to have full range of motion with that arm. Maybe that arm cannot be fully extended. So, the contractures to this elbow, maybe also to the shoulder, where they can maybe only bring it up this high. You can imagine with these contractures, these individuals that are bedbound, you have to dress them in bed. It's going to be very, very hard with contractures, right? So we want to make sure we're repositioning our people at least every 2 hours, and then providing range of motion exercises if we have a doctor's order for it. So cyanosis, this is going to be blue or pale skin and or mucous membranes due to decreased oxygen to the blood. So, you ever see that child in a pool and their mom's saying, all right, honey, it's time to get out. And they're going, oh, no, it's not. And their little lips are blue, right? They're getting cold. Those are signs and symptoms of cyanosis. We see them often, the lips, right? They'll get that bluish tinge. Sometimes the nail beds. I'll see somebody ambulating, starting to struggle. I'll look at their hands and I'll see almost a bluish tinge to their fingertips. All right, that's when we know somebody needs to sit down, catch their breath. Dysphagia. So we said dys means difficulty. Phagia is going to have to do with swallowing. People with dysphagia are going to be at risk for aspiration. If something's flammable, we're going to say it's easily ignited, capable of burning quickly. It's important we're talking about flammable combustion because we have a lot of residents on oxygen, right? Oxygen is very flammable. When somebody is hoarding, they're collecting and putting things away in a guarded way. We don't know a lot of the times when these individuals move in what their life was like at home, right? If you've been a hoarder when you were living at home, those behaviors aren't just going to go away because you moved into a long-term care facility, right? So trick is to keep these people safe. All right. So I will give you an example of a hoarding situation. Now, fair warning, you're going to need a little bit of a strong stomach for this one. All right. I took care of a lady in an assisted living. Okay. I went into her room one day and I was like, something's smelling a little funky. Where is this smell coming from? We looked all around. I looked through her fridge, cleaned it out, looked through, and we deep cleaned the bathroom. We could not find it, and it kept seeming to get worse. We checked all the cabinets, any food she had. We could not figure it out, but it definitely smelled like something was rotten in there. Okay. Then one day, I go in a room. She's like, oh, I dropped my remote. It was next to her bed. It kind of got under her bed. So when I went to go pick up the remote, I looked under her bed and I found the source. So this resident used to have her son come visit her once a week, all right, and he would bring in supper for them. Now, they really loved those rotisserie chickens that you can get at the supermarket. All right, he would get that, a couple heat up sides, and then they would sit down and eat together. Well, when he would leave, he would not take the trash with him. He would leave all the leftovers for her. So when I looked under that bed, I found a half a dozen chicken carcasses in various states of decomposition. As you can imagine, definitely an infection prevention and control issue, having decomposing food. They were all removed. And then we did talk to the son that if you want to come and have dinner with mom, wonderful. But please take the leftovers when you leave. Okay. Was not a very pleasant thing to walk into, right? But sometimes these things can happen because what you want to know is that individuals that hoard, okay, it's usually because they've endured some sort of trauma in their life, some sort of loss. So the brain, almost like in a PTSD way, rewires itself. Okay. And they start to believe these possessions. Sometimes it's something specific. For this woman, it was leftover food. For other individuals, it might be something maybe a little harmless, like the medicine cups that we give. But they'll not want to throw them away. They have to keep them. It's very guarded. It causes them a lot of distress to give up these things. Okay. So in long-term care, assisted living, any healthcare setting, our job when it comes to these individuals is to keep them safe. Okay. So if they're hoarding something not unsafe, maybe we can control it a little. That resident I told you about that tends to hoard medicine cups. Okay. It's not causing a problem, but if it's in the top drawer of her side table, I sometimes will take a few out, right? Make sure it's just staying to that one drawer. So intravenous therapy, you often see this as IV. This is the delivery of medication, nutrition, or fluids through a person's vein, and it's through the use of a catheter. PASS. This is an acronym you'll learn when you do fire orientation, fire safety. It basically deals with how to handle a fire extinguisher. You pick it up, you pull the pin. The pin keeps it from being squeezed too early. You're going to aim it at the base of the fire. You cannot take out the fire from the flames. You have to go to the base. You squeeze the handle, and then you do a side-to-side sweeping motion. A physical restraint, this is going to be any method, device, material, or equipment that restricts a person's freedom of movement. Remember, Deauville, where you'll be going, is not a restraint-free facility. Particularly, they have alarms. Alarms are considered a type of restraint because they inhibit that person's ability to move freely. RACE, this is another acronym in the emergency that there is a fire. So if there is a fire in your facility, you want to first R, rescue. You're going to rescue the residents and patients in the immediate area and get them out. A is activate. You want to activate emergency services. So call 911, pull the fire alarm. C is contain. We talked about oxygen is highly flammable and it helps feed the fire, right? So we want to close all doors, close all windows. And then last E is extinguish. Extinguish, I will say 99% of the time, you're not going to try and put that fire out, okay? So E stands more for evacuate. Your job is to keep yourself and those residents safe. So they will train you what rooms, residents you're going to be responsible for getting out of the building in the event of a fire. So general, the word restraint is a physical or chemical way to restrict voluntary movement or behavior. It's important we talk about restraints because a lot of facilities now are trying to go restraint free. Okay, they'll say, why are we using these alarms? What alternatives can we use instead so that we don't need them? And that word is going to be restraint alternatives. These are going to be measures used in place of a restraint or that reduce the need for a restraint. So think, why does that person keep trying to get up if they're unsafe, if they're a fall risk? Is it that they're restless? They need to be ambulated, walked to get out that restless energy? Is it that they need to go to the bathroom and we need to start putting them on a regular bathroom schedule so that they don't get up on their own? Is it that they're a little bored and we should start giving them more tactile, hands-on activities to keep them entertained? I had one resident who it was like a spring in his pants. Every time he would go to sit down, he was whoop, up again. All right. He came to my facility. This was a locked dementia unit because the wife couldn't keep him safe at home. He kept wandering around, getting into things, right? So we did a little research with him and found out, and the wife was very surprised, found this, he actually really liked coloring, right? So we actually found some different coloring books, different coloring pencils for him, and it would actually get him to sit down for about 30 minutes to an hour sometimes. Right? So sometimes you just have to find what that person is going to be entertained with, right? Person-centered care. So restraint-free care, this is an environment in which restraints are not kept or used for any reason. Like I said, a lot of healthcare facilities are moving in this direction. Safety data sheets, or sometimes you'll see safety data set, known by its abbreviation, SDS. These are sheets that provide information on the safe use of and hazards of chemicals, as well as the emergency steps to take in the event chemicals are splashed, sprayed, or ingested. So the SDS sheets are at Deauville. Your instructor at clinical will point out where they are for you. It's a very, very big book, probably about this big, because any chemical or substance used in that facility has to be listed on those safety data sheets. All right. And it's going to tell you if it's toxic, if it's not, how to clean it up. If it gets on you, is this an emergency? Is this something you can just wash off, rinse out, and you'll be fine? All going to be in that information for you. So scalds are going to be burns caused by hot liquids. Very important that you're careful with liquids when you're giving them to the residents. Make sure they're covered, make sure they're not on the edge of a table they can fall over, and that they're within reach of residents. Another consideration is that a lot of times as we get older, we lose our sensitivity to heat and cold. Probably all of you that are watching this have seen probably someone go, this isn't hot enough, heat it up more, to the point it's boiling, right? It's not that it's not hot enough, it's that they can't sense that heat as well. So we have to be careful with these individuals that we're not heating up their food and fluids too much because of the risk of scalds. Suffocation is the stoppage of breathing from a lack of oxygen or an excess of carbon dioxide in the body. May result in unconsciousness or death. Suffocation is something we have to talk about when we talk about the risk factors of restraints, and another reason why a lot of facilities are going restraint-free to lower those chance of injuries. So there are many types of accidents that can occur in a facility. When nursing assistants are proactive, they can help prevent accidents. Remember, you're in and out of those rooms, interacting with those patients more than anybody else. You're going to notice not only when something medically is off with them, but maybe when something's off in their environment. You're going to notice when things are unsafe in their room. So very important, you're reporting these things to the nurse. So Hartman Hills is short-staffed. Nursing assistant Yesenia is caring for twice the number of residents she usually cares for. Mr. Gao has been using his call light often, and Yesenia decides he will have to wait while she finishes caring for Mrs. Lowe. Uh-oh, right? Making people wait on the call light can be considered abuse. When she arrives in Mr. Gao's room, he is just about to trip over a cord. Uh-oh, stretched from an outlet by his bathroom to his bedside table. So in this situation, it's probably going to be reflective to you that you're going to want to try and catch Mr. Gao. All right? Don't try and prevent him from falling, because if somebody is not within arm's reach to you, that is the only time I do an assisted fall. I help lower someone to the ground. Your risk of injuring them and yourself is more greater than you actually stopping them from falling, right? I'm not a petite girl. You can imagine if I went, oh, Mr. Gao, and went to go try and catch him, Mr. Gao falls, I fall on top of him, right? It's going to cause worse injury. So you don't want to try and catch Mr. Gao, all right? If he falls, get the nurse, we'll assess, we'll try and get him off the floor, okay? Things we can do that she could have done differently. Once again, she should have answered that call light, right? As long as Mrs. Lowe was in a safe situation, call lights are the priority. And then another thing, if she saw the cord stretched across the walkway, she could have plugged the device in somewhere else, move it so it's not a tripping hazard. So other general guidelines for preventing falls, you want to know which residents may be at risk and report their unsteadiness. You want to keep frequently used items close to the residents, including call lights. Respond to them promptly. Make sure eyeglasses are within reach and they are not damaged. You're going to wipe up spills immediately. Remove clutter from walkways. Keep purse, bag straps, and linens off the floor. Get help when moving residents. Lock the bed wheels before giving care, right? Our opening steps. Always want to remember locking the bed wheels. Lock bed wheels before moving a resident into and out of bed. Lock the wheelchair wheels before transferring resident into and out of them. Return bed to their lowest position when finished with care, and make sure residents' clothing fits properly. Make sure residents are wearing sturdy, non-skid shoes with laces tied if they're getting out. If they don't have shoes, you can get those non-skid slippers, right? Those socks. They have those traction marks on the bottom. Report loose handrails immediately, any cracks or holes anywhere, any damage to furniture, benches, ramps. If an area of the floor is uneven, speak to the staff, maintenance about marking those areas for people. Keep walkers and canes nearby residents. Do not move furniture without an order from the nurse. Offer trips to the bathroom often. Respond to requests for bathroom assistance promptly. Report any areas that are not well lit. Do not try to catch or stop a falling resident. All right. Remember, they're going to get injured. You're going to get injured. If they are within touching distance of you, so within arm's length. So for instance, only time I do an assisted fall is if I'm ambulating someone, walking with them, and I have my hand on the back of their gait belt. You can go behind, bring your arms around, hold the gait belt, and slide them down your body to the floor. But that is the only time I'm attempting that. And you want to report all falls to the nurse right away and complete an incident report. So most of the accidents in a facility are related to falls. Falls are often caused by unsafe environments, loss of abilities, disease, muscle weakness, poor vision, or disorientation. So Vance is a new NA, nursing assistant. He remembers from his training that it is very important to check a resident's identity before providing care or serving meals. Before serving a meal, he checks the diet card and asks the resident to state name and date of birth. You're not always going to do this once again, long-term care, because with dementia, they might not know or remember their date of birth, right? But this is par for the course in hospital settings. He later learns that there are 2 residents at Hartman Hills named Timothy Brown. One of them is allergic to shellfish. Right? So it was very good that he used those 2 steps in date of birth, right? Because if 2 people have the same name, very low chance they have the same birthday too, right? So you always do want to check both in those cases. It's going to be very important when you're identifying residents to identify them before the care of serving food, check those diet cards against residents' identification, and call the resident by name. Okay, so in this case, if I was Vance and I had 2 residents with the same names and I was in long-term care, I would probably be second checking with the staff, the normal staff too, to make sure I have the right person. Oh, we got a question. So if a resident begins to lose balance but catches themselves before reaching the floor without your assistance, how would you report that to the nurse? So unfortunately, it would be an almost fall. So you're still going to report that to the nurse. And because it's an unexpected occurrence, it's still going to need an incident report. All right. And you would just, when you're reporting that, Ray, state the facts. You know, I was ambulating resident. She got unsteady in her feet, but was able to catch herself. So the nurse won't have to do as much paperwork, still considered an incident, but we wouldn't consider this a fall. But we would want to document it, make sure we're following up with the therapist as well, and making sure that our staff know proper techniques when ambulating with these individuals. So remember, failure to identify residents can result in illness or even death, right? We don't want the wrong people getting the wrong food tray. And it has happened, unfortunately, on clinical before, not in my class, but another instructor. They gave the wrong tray to the wrong resident, right? So be careful. So Mrs. Elskov prefers her coffee very hot. Nursing assistant Ruthie knows this and makes sure she serves breakfast to Mrs. Elskov first. Mrs. Elskov is watching birds at a window feeder when Ruthie comes in with her tray. Her hearing aids are not in. She does not realize Ruthie is there until Ruthie is putting the tray down. Mrs. Elskov is startled and bumps the tray, knocking the hot coffee over. Oh, so remember, we get a hot liquid across the skin, we are at risk for what we said is called a scald. Okay, could be a scald. So very important. What I would have done differently to prevent this, right? If somebody is hard of hearing, you have to get their eyes, right? So I wouldn't have gotten close to her or even set the tray down. I would have knocked, announced myself, and if she didn't reply, kind of walk in the room, give a little bit of a wide berth so I didn't startle her until I got to her face so she could see me, right? And then I'd say, "Hi, how are you?" And then go to put the tray down. Okay. Also, if that coffee is that steaming hot, we should probably forewarn her of how hot it is, right? Give her a heads up before putting it down. Okay. If it is as hot as you say it is, where it could cause a scald, maybe set it aside. Let it cool down before giving it to the resident. So, guidelines for preventing burns and scalds, we always want to check water temperature before giving a resident a bath or shower. Usually, rule of thumb is if you have a bath thermometer, most people don't, okay? But temperature should not be over 105 degrees Fahrenheit. You want to check for proper temperature of any warm water applications, and you're going to use low settings if you're using a hair dryer. Let liquids cool before serving. Serve drinks when residents are seated. Tell residents before pouring or setting down any hot beverages. Use lids with hot liquids. Pour hot liquids away from the resident. Check the plates because sometimes when food comes out, the plates have been warmed. So be wary of that and forewarn them if the plate's warm. Make sure anything that has been in the sun has cooled before use, and tell residents about smoking precautions. You won't have to worry about that as much at Deauville. It is a no smoking facility. So that means no smoking inside or even outside. But some places you work at will allow residents to do that in designated areas. But usually the rule of thumb is if they do go outside to smoke, you need to stay with them at all times. So burns are very painful and they can occur quickly. Elderly people and those with loss of sensation are going to be at greater risk of burns. Mrs. Yazzie is in the memory care wing of Hartman Hills when she starts to vomit. Nursing assistant Susanna goes to help care for her and finds a partly eaten, very out of date container of yogurt on Mrs. Yazzie's bedside table. She looks in the drawer and sees that Mrs. Yazzie has been hoarding yogurt containers from her breakfast tray for a long time. So once again, this is going to be a situation with hoarding that we have to do more to control, right? Because expired food is a safety hazard. Okay. So very important when we go to start collecting Mrs. Yazzie's breakfast trays that we make sure items have not disappeared. And then we're probably going to have to start checking the drawers regularly for hoarded food items. So guidelines specifically for poison prevention, you want to keep all items that may be poisonous away from disoriented residents. And sometimes, in all honesty, it doesn't have to be just poisonous. At one point when I worked on a locked dementia unit, I had a woman, we were getting breakfast ready, and I went over and she had actually grabbed the plant on the ledge and had a spoon and was eating the dirt. And when I went to go take it away from her, she was like, "Hey, I'm not finished yet." Right? That's unfortunately sometimes the confusion they have. So you have to be wary of even basic household items sometimes as well. And then you want to always make sure there's proper ventilation if you're using any chemical products to clean this up. So since his stroke, Mr. Leisman has been experiencing dysphagia. Remember, difficulty, phasia is swallowing. So this is going to be difficulty swallowing. Nursing assistant Khadijah knows that he is at risk for aspiration. Remember, that's when food, fluids, foreign material gets into the lungs because of his difficulty swallowing, and this can lead to pneumonia. He could also choke. When helping Mr. Leisman with meals, Khadijah cuts his food into small pieces. She encourages him to take a sip of water between bites, and she makes sure he is sitting upright. All great things to do when we're feeding dependent residents. And we'll get more into this too with nutrition, but very important when anybody's eating, whether it's in the dining room, in their bed, wheelchair, we want to sit them as upright as possible, as close to 90 degrees as possible. Wink, wink, might be a test question, right? As close to upright as possible. You want to give them smaller bites, sips of fluid. I never Don't offer a fluid more than 2 or 3 bites, fluids to kind of rinse it down. Okay. You want to assist with feeding slowly. Never rush a resident during mealtime. Cut food into smaller pieces if they need it. Report to the nurse if you think the resident would be helped by softer foods or thickened liquids. We can get a speech therapy eval. See if they're having swallowing difficulties and change the textures of their food. And then the thickening of their food, I'll show you guys that in class. It's called thicket. Doesn't have a taste, doesn't have a smell, just changes the texture of things. Make sure dentures are in place and that they fit properly. And then be aware of residents' swallowing precautions. So nursing assistant Camilla is taking Mrs. Johnson, who is in a wheelchair, to a common area to watch her favorite game show. I'm guessing Wheel of Fortune. That was a big one in my household. They are almost there when another resident Camilla cares for activates her call light. Okay, so she's got some multitasking to do. What is Camilla going to do? Probably not the right thing. Uh-oh. She speeds up, turns a corner very quickly. As she does this, Mrs. Johnson's arms hit the wall, breaking her wrist. Okay, so let's talk about how could this have been prevented? Well, first, Camilla could have asked Mrs. Johnson to wait, right? It's not an emergency. She's just going to a game show. You're not in the middle of toileting someone or personal care, right? So she could have asked her to wait and then gone and checked on the other resident. If Mrs. Johnson was not able to be left alone for a short amount of time, Camilla could have wheeled her to the other resident's room, but have her wait outside in the hallway, but where her eyes are still on her while she checked on the other resident. If the other resident's room was close to the common area, she could have slowly finished the trip to the common room with Mrs. Johnson, then left her there and gone to check on the other resident. Okay. But very, very important. One, you never go too fast down hallways when you're pushing a resident in a wheelchair. Two, be wary when you go around corners. Sometimes people aren't paying attention. They come quick. You don't want to collide. Other consideration, I do see people, a lot of times it's bruises to the elbow. Make sure some of these doorways are kind of narrow. They just fit the wheelchair. Remind the resident to tuck in their arms and elbows when you're moving them in the wheelchair. Okay. Other guidelines for preventing cuts, scrapes, other injuries: do not leave sharp objects out. You can prevent skin tears when dressing residents by guiding the clothing over their body, right? Also, by not having long nails, right? And always you want to approach doorways or turns, corner turns, slowly. When moving residents in wheelchairs, protect their arms, legs, hands, and feet. If you are going down a ramp, you go backwards, right? Because can you imagine if you went forward, what would happen if you lost your handle? Woo, Mrs. Smith is going for a ride. We don't want that to happen. So you go backwards, okay? And then when you go in elevators, same idea. You go backwards, so then that way when the elevator doors open, you can just go straight out. And remember these points, wink, wink, might be on a midterm or a final. So nursing assistant Marjorie is asked to remove bedding and to remake a bed for a resident who is gone for the day, having outpatient surgery. She goes to the resident's room and pulls the bedding back to make sure nothing has been left in the bed. Good girl, before taking the linens off. As she works, Mrs. Singer, the resident in the room next to her, activates her call light. Marjorie walks to Mrs. Singer's room. Mrs. Singer needs help getting out of bed and onto a bedside commode. Marjorie calls another nursing assistant to help. So ask yourselves, do you think Marjorie did the right thing? What do we think is the priority? Finishing making that bed or helping someone to the bathroom? If you said helping them to the bathroom, you would be correct, right? There's no reason that she can't go over and help Mrs. Singer on the commode, and that making of the bed can wait a little while, right? You always want to, of course, check that bed. I did agree with that before removing linens for anything that might be in there. Okay. You want to review these general safety rules. You never want to run in the facility. Okay. You'll get something like I call a nurse's walk. It's like one step below a run, but I walk with a very determined purpose. Okay. Because you get busy. You're doing a lot of things, right? You do not want to put your hand into a bed or anything else without looking at it first. Ask for help when you need it. Know what residents are combative. Try to learn what triggers this behavior. Follow your facility policy if a skin splash or eye splash has occurred, and we're always going to report all injuries immediately. So remember, OSHA is responsible for the safety of employees at work. OSHA is the one that requires all dangerous chemicals, any chemical that's used in the facility, to have an SDS. These sheets are placed where all staff can exit them. I'm not quite sure where they are on Wanalancet, but for those of you that end up going into Belvedere, they're actually put right in front of the room where the elevators are. Okay. So when you look at these sheets, you're going to find some different information. It's going to list the chemical ingredients of the product, the dangers of the product. There'll be pictograms indicating the types of hazards associated with the product. Protective items that have to be worn when you're cleaning it up. How to use and clean up the chemical. Emergency response if the product is splashed onto the skin or ingested, as well as safe handling, storage, and disposal procedures. So nursing assistant Daniel has just finished shaving Mr. Rob with a disposable razor. He has the razor in a tissue he used to dab blood from a small nick on Mr. Rob's skin. How should we dispose of the razor and tissue? Okay. So very important, safety guidelines for using sharps and biohazard containers. You want to don gloves before touching the sharp container. Keep your hands clear of the opening of the container. If you are transporting one, carry it by the bottom only. That shouldn't happen though. It should be the nurses that when they get full, take the old one out and put in a new one. Request that container be replaced when it's 3/4 full. And you'll see the line actually on the container will be, report and replace when this full. Okay, so it's right on there for you to see. And those sharp containers are one of the things you'll see staff kind of hectically going around and checking, okay, when state surveyors come in, because we can get cited if our sharp containers are full. So they'll go around and be like, are these ones full? These ones full? And start changing them out. You want to wear gloves when disposing of infectious waste. So in this case, she should have been wearing gloves throughout it. He should have been wearing gloves throughout anyway, right? Because the risk of exposure to blood. You're going to remove gloves, wash hands after putting anything into a biohazard container or bag. Okay, so the little tissue with blood should go into a biohazard bag if there is one there. Okay, sharps is going to go into the sharps container. Okay, anything sharp should always go into a container that's solid where it can't pierce. So never put a used razor in the trash. So, true or false? Good body mechanics can prevent injury. What do we think? I'll give you time to think about it. Did you say true? You're right. It is true. It is true. Good body mechanics help save energy. They prevent injury and muscle strain. When muscles are used correctly to push and lift objects and people, it reduces the risk of injury to not only you, but to your residents as well. So remember, using the basic principles of body mechanics can help keep nursing assistants and residents safe. So here we have our individual. It's going to be doing some lifting, looks like. Maybe you already did lift up this box. Want to show very, very important with body mechanics, alignment. You want your body to work as one unit. You never want to twist at the waist, right? Make sure you know these. Wink, wink. Might be a test question, okay? But your body should be in alignment. So when I have to go turn, I'm moving my body as a unit. I'm not twisting at the waist. I'm rotating it together. You should have a good solid base of support, at least shoulder width apart. For my taller students, if you got to get down a little lower, it might have to be even a bit wider than that. Okay. Very important. Bend the knees, low center of gravity. Okay. And if you noticed when we were doing some procedures and I was telling you guys about the incontinent pad and how we boost residents in bed, before I even move them, I take a second to hold that incontinent pad. I bend my knees and I do a little bounce. The reason I do that bounce is to kind of get a feel for my center of gravity and to make sure it's nice and low. Make sure my back is nice and straight and that I'm prepared before I do any lifting. So we got two people here. One's using good body mechanics. The other one, looks like they're about to fall head first, right? So my friend on the left there is not using proper body mechanics. He did bend his knees a little bit, which is good, but he bent more at the waist. His back isn't straight, it's bent. And then where's this gentleman's center of gravity, right? Only takes one little flick of that bottom and he's going to fall right over, right? So not good body mechanics. He's straining his back. He doesn't have a good center of gravity. He's more likely to fall or hurt himself. Then my friend on the right, he's doing it the right way, right? He's trying to keep his back as straight as possible. He's bending with his knees, using his thigh muscles to lift, right? What I always say, guys, if you have to pick something up, drop it like it's hot, right? You're going down as a unit and then coming up. Don't bend at the waist. That's what's going to hurt your back. All right, so when we are talking about body mechanics, we're going to be doing a lot of different tasks, right? Not only the lifting of residents, but we might be helping with laundry, luggage, trash bags. So rule of thumbs for good body mechanics, we always want to raise the bed to a safe working height, right? Especially when we're moving, lifting residents. We want to stand close to an object. I always see when I see my students learning to transfer a resident for the first time, they go to put their hands on the gate belt and they're out here holding them, right? That's not a good way to lift someone, right? Because if they're all out here, are you going to have really good center of gravity? No. All right. But I always say in healthcare, there's really no such thing as a personal bubble. You got to get all up in somebody's grill. Okay. So get in there. Put your arms around them to fully pick them up. I bring them close to me. I'll even say, give me a hug, right? I'll let them put their arms around me because the closer they are to me, the better I can keep center of gravity and the better I can keep them safe when they stand. You want to push or slide objects rather than lift if you have a choice. Once again, we're going to use the strong muscles in our thighs, upper arms, and shoulders to lift. You want to bend at the knees, do the squat, drop it like it's hot, right? Avoid twisting or choppy movements. You want to face the object or person being moved. And like I said, we're not twisting our waist, so we're going to be pivoting our feet and moving as one unit. Do not lift with one hand. Avoid bending or reaching. So yesterday, a couple of you, when you were doing skills, or even in the Hartman skills videos we were doing, right? They would have to do something on the opposite side of the bed and they would lean their whole body over. Don't do that. It's going to hurt you, right? Be on the side of the bed that you're working on. All right. Have the side rail down on the side you're working on, side rail up on the side your resident is facing. Okay. If you need help, if you're struggling to move somebody, there is no shame in saying, hey, can another CNA come in to help me? Right? Get help when you need it. I'd rather you go get help than strain and hurt your back. Okay. Talk to the resident too before moving them and agree on a signal for moving so they know when to put in the effort to help you. Okay, so we talked about different types of restraint. We said a restraint is a physical or chemical way to restrict voluntary movement or behavior. A physical restraint is going to be any method, device, material, or equipment that restricts a person's freedom of movement. Chemical restraint is specifically going to be medications used to control a person's mood or behavior. We have to be, like I said, very, very careful with psychiatric psychotropic medications, and they do routinely have to be reviewed for therapeutic use. So restraint use has declined in facilities, and laws have been passed restricting their use due to the abuse of caregivers. Please remember this question, test question, wink, wink. Okay. Restraints may never be used without a doctor's order. All right. Doesn't matter if you're short staffed, doesn't matter if the resident's aggravating you, right? You can never use a restraint for those reasons. That would be considered abuse. You can only use restraints with a doctor's order. And then the nurse does have to specifically care for it. So imagine being unable to move your body freely for an extended period of time. Think of our bedbound residents, right? We talked about the risk that can occur, atrophy, contractures. What else could be potentially negative effects of if we use a restraint on people? Not only are they bedbound, but then they can't move. They can get bruises, cuts, pressure ulcers. You have a risk of strangulation or suffocation, entrapment. We're not moving. We're at heightened risk of pneumonia. We have reduced blood circulation, more stress on the heart. We're possible to get blood clots because we're not moving our limbs. Can lead to poor appetite, malnutrition, dehydration. We can't get up. We can't use the bathroom. So now we're at risk of incontinence, urinary tract infection, constipation, loss of bone mass. You can get nerve injuries, falls, fractures. And that's just the physical, right? Mentally, how can you feel if you're stuck in a restraint? It can lead to depression, withdrawal, social isolation, a loss of self-esteem, loss of dignity, independence, can cause stress, anxiety, agitation, confusion, can lead to sleep disorders, severe injuries, and even death, right? Lot of risk factors for using restraints, which is why a lot of people, like I said, are moving away from them. So what do we think? Can a restraint be used if staff do not have enough time to care for residents? How about can restraints be used if the resident has made a staff member mad by arguing with the staff member or being in a bad mood? Did you say no to both? You are correct, right? Both of these situations would be an example of abuse, okay? Very, very important. In these cases, you need to look into restraint alternatives, right? Restraints can only be applied with a doctor's order. So remember, restraint use has been dramatically reduced in facilities. State and federal agencies encourage facilities to take steps to create restraint-free environments. Creative ideas that help avoid the need for restraints are being used instead. And once again, we call these creative ideas restraint alternatives. Important to note that studies have shown that restraints are not truly needed. People tend to respond better to the use of creative ways to reduce tension, pulling at tubes, wandering, or boredom. The other thing about that is if the behaviors aren't hurting anybody, do you necessarily need to do anything about them? Okay. Told you guys about my adult day health. It was a locked facility, so nobody was going to elope or escape. We had all hazards locked up. Nurse's station was locked up, but they had a beautiful little circular hallway, lots of light that they could just walk. So if I had a participant who did wander or pace, they were free to do so because they were in a safe environment to do so, right? So it's a consideration. The behavior is not bothering everybody if it's not making them unsafe, or if you can maybe make some changes to make it safe, there's no reason to try and stop it. So think of your own ideas, ways to avoid restraints. So some suggestions: making sure call lights are within reach, answering them promptly. Use fall prevention and other safety techniques, such as improving lighting. Certain types of grab bars can also assist with moving in bed and getting out of bed. Take the resident on a walk. Sometimes they're just restless, right? They just want to move. I know me personally, I can't stay in bed too long. I got to get up. I got to move. right? Even talking to you all here, if you haven't seen me on Zoom, you'll see I constantly readjust, okay? You need to. We want to encourage our wheelchair bound residents to reposition themselves every 15 minutes if we can, okay? Let confused residents wander if it's in a designated safe area. Provide activities for those who wander at night. I was an overnight nurse, so I would have some what I called frequent flyers that didn't sleep well at night. A lot of the times they were individuals that were late night or overnight workers themselves. So that was just their schedule, right? So if they couldn't sleep, that was okay. I would bring them out to the nurse's station with me. Maybe we do a little bit of an activity to tire them out. I had a resident that used to play some lovely games of cribbage with me if time could afford it. Okay, maybe get them a snack, something to drink, and then we just return to bed later. Give frequent help with toileting. Help with cleaning immediately after an episode of incontinence. Remember, all of our incontinent residents, we're going to clean at least every 2 hours or whenever an incontinent episode occurs. Make sure residents are clean, dry, comfortable. Encourage independence with all tasks, but provide meaningful activities. Encourage participation in social activities. Escort the resident to social activities when needed. Try and increase their visits if you can, social interactions. Offer reading material that the resident enjoys. Read to the resident if needed. Increase the number of familiar caregivers with family members and volunteers. Maybe they just need an extra person. Some facilities, Duville actually will, surprisingly, provide a one-on-one. So that's like your own CNA to watch them to keep them safe. But a lot of facilities I've worked at, even long-term care, if somebody gets to the point where they're unsafe completely on, and they need what we call a one-on-one, we'll ask the family to provide additional resources outside to do that. So it's an additional cost. They have to find their own aide to come in and sit with the resident overnight, if that's where we're at in the point of their care. Okay. Offer food and drink. Maybe they're just hungry. Maybe they're thirsty. Decrease the noise level. Offer back rubs or use relaxation techniques. Listen to soothing music. I had a couple times I'd have a resident that would be upset. So I'd bring them in with me to the activity room. I'd take away the extra noise, the lights, and then I would play just some soothing music on my phone for them, some acoustic alchemy, something like that. Like elevator music, the little acoustic guitars going. If nobody here's heard of acoustic alchemy and you really like the sound of acoustic guitars, look them up. They're quite nice to listen to. And sometimes just being in that calming environment can help kind of them settle down. And as always, we want to monitor residents closely and report complaints of pain to the nurse immediately. So if a restraint is ordered, we do have some guidelines. We're going to follow the care plans and the nursing's instructions for monitoring. We're going to place that call light within the resident's reach and respond immediately to the call lights. We're going to perform care as ordered. And as always, we're going to document appropriately. Because remember, we document or it didn't happen. So we talked about that term cyanosis. Remember, cyanosis is when basically we're having a lack of oxygen in the blood to an area of the body. Of course, this can happen and is a risk factor of restraint use. So observations that you might see that can be indicative of cyanosis might be purple, blue, or darkening of the skin, okay, redness, discoloration, and/or swelling. So think of it this way. Was anybody here ever as a kid, they took a little, maybe it was just me. We took a rubber band and you strapped it around the end of your finger and then you saw your finger start to turn pink blue and went, oh, look at that, right? Well, what you were doing is you were cutting off circulation to that limb. That's what we worry about with restraints. We don't want that to happen because if we're cutting off blood flow, nutrition, we can start to have something called necrosis or tissue skin death. So we talked about oxygen supports combustion. This means it helps things burn. Okay, so this is why flammable liquids, candles, matches, lighters should be removed when oxygen's in use. Most long-term care facilities do not allow residents to have any flammable items on them. So they cannot bring candles, lighters, anything like that in. Oxygen increases the danger of fire when these items are near. Okay. More what you need to be concerned about is sometimes your hoarders when it comes to books, paper, and they're on oxygen. I've seen it. All right. You go in their room, their oxygen concentrator. That's how they're getting their oxygen. It's coming through the tube in their nose, nasal cannula, we call that. Okay. It sits on the ground. Not supposed to have anything that could start a fire near it, right? Well, I had a resident that loved to read, just moved in, didn't have a place for all of her books. So paperwork too. So she started stacking it, stacking it, stacking it all around her room. Well, guess where it was also all around? That oxygen concentrator, right? We don't want that to happen. It would take one little match, one little spark, maybe an electrical surge for you to have the perfect environment to start a fire, right? So these are those times we want to intervene. Anytime somebody is on oxygen, we do have a sign up. We're supposed to put one up, oxygen in use, no smoking allowed. So people are aware. So important to know, oxygen is a medication. It's a treatment. So it is out of your scope of practice to turn it off or adjust oxygen levels. All right. That's going to be the nurse's responsibility. Now, Mrs. Smith is on continuous oxygen via nasal cannula. Remember, that's the tube that goes up around your ears into your nares or nostrils. Okay. And she takes it off, throws it on the floor. She doesn't want it. I don't want this oxygen. Yes, you'll find residents that do that. Okay. You can, within your scope of practice, get oxygen tubing and help put it back on. Okay. You can, if it's off, turn it on for them. Okay. If they have an order for it, if they're on it. Okay. But you cannot turn it off or adjust the level. So say you walk in a resident's room, they're on oxygen, they're short of breath, they're struggling. You can't walk over to the oxygen machine and go, oh, well, they're on 2 liters. Let me up it to 4. No. That's out of your scope of practice, right? One thing you can do, and I found this often when I was working hospice, and I'd have people tell me they were having issues with their oxygen, check the tubing. A lot of the times people on oxygen, they still ambulate or self-propel in their wheelchair around their rooms. So their oxygen tubing has multiple connections. And it's these long circles and trails of tubing. And what can sometimes happen is they can get bent, kinked, or stuck. And then that's going to stop the flow of oxygen to your patient or resident. So most of the times, home health, I'd get a call, my oxygen isn't working. I'd go over, check the tubing. There was just a kink in it, right? So first line of defense, after you get the nurse right away to respond to this situation, if you want to help out, check the tubing. Make sure there's not kinks. And what I do personally, you don't have to do this as CNAs, but as a nurse, if I want to make sure the oxygen's flowing, I'll even bring up the little nares part where the oxygen is coming out, and I'll hover it over my wrist, which tends to be a sensitive part. You can check water temperature this way, but I'll hold it over and just see if I can feel the oxygen coming out too, to kind of verify it's flowing okay. Okay, so things we can do to promote safety with oxygen, okay? Promote people's comfort with oxygen therapy. First and foremost, safety is most important, right? So we're going to post that no smoking and oxygen in use signs. They have to be at eye level. We're going to remove fire hazards from the room. So my little friend with all of her books, nothing matter with having books, but we had to move them. They could not be stacked around that oxygen container, right? Let me see, we're going to remove any flammable liquids from the area. We're not going to allow candles, lighters, matches around the oxygen. We're going to check the nasal area, cheeks, and behind the ears for signs of irritation from the tubing. The tubing can get very irritable. There is a lever where you can go bring it up so secure it around the chin, but sometimes it starts to leave some reddened implants along the cheeks, or oxygen can be very drying. So sometimes it can irritate the nostrils. What you can use is a water-based lubricant to help with the nose, maybe under the cheeks a little bit. Remember, it has to be water-based lubricant. Petroleum-based lubricants can actually break down the plastics in that tubing. Okay. Make sure the resin is not lying on their oxygen tubing and check that there's no kinks in it. Learn how to turn off oxygen in case of a fire and never adjust oxygen levels. Once again, I did just say you never turn off oxygen, right? But some facility policies check, let them know that when you have to evacuate in the event of a fire, everybody gets put on a portable oxygen tank that's getting taken out. And sometimes then they'll tell staff, because once again, we don't want to feed the fire, to turn off oxygen concentrators in the facility. But you'd have to work with their policies in order to be able to be allowed to do that. So IV is going to be an abbreviation for intravenous, which means into the vein. Resident with an IV is receiving medication, nutrition, or fluids through that vein. Could be one, could be two, could be all three they're getting. Okay. So very, very important. When we are dealing with IVs, we always want to wear gloves, right? IVs are going directly into a resident's vein, so blood may be present. Remember, we're going to treat all blood bodily fluids, standard precautions, like they're infectious. As well, IVs, right, are bypassing our body's first line of defense, our skin. It's giving that roadway into the body. So IVs do increase the risk of MDROs, multi-drug resistant organisms. Cleanliness is going to be very important to protect both the nursing assistant and the resident. Okay. So, how we're going to take care of a resident with an IV, or certain considerations we need to consider. Very important, if the person has an IV, we do not take a blood pressure in that arm. Okay, we never do that. We don't want to get the IV site wet, right? Remember, bacteria growth loves what? Warm, dark, and moist. So we don't want to add moisture to it. We want to make sure we never pull on or catch tubing in anything. We're going to leave the tubing kinked if it is. Lower the IV. Oh, I'm sorry. Get myself confused. Going back, sorry. You want to make sure that the tubing doesn't get kinked, okay? You never want to lower the IV bag below the IV site. You never want to touch the clamp. And you never want to disconnect the IV for the pump or turn off the alarm, all right? If the IV is sounding, get the nurse. So nursing assistant analyst is helping Mrs. Powell get dressed. Mrs. Powell is receiving IV fluids. What should analysts observe about the IV while she helps Mrs. Powell? What would need to be reported to the nurse? So considerations when you're handling an IV, when you would want to get the nurse, okay? 1, if the needle or catheter has fallen out. We no longer have IV access. We need to know that, right? Especially if we have an IV drip still going. If the arm board or hand board becomes loose, some individuals will have their limb secured to a board to keep it stable. Tubing is disconnected. If you see any blood backing up into the tubing, all right, because when that happens, the blood backs up, it can coagulate, and now we're going to lose access to that IV site. We're going to have to start a new site somewhere. If you see the IV fluid in the bag or container is gone or almost gone, you want to know. If the IV fluid is not dripping or is leaking or the bag breaks, if the IV pump is beeping, if the resident complains of any pain or has difficulty breathing or a fever, they could be reacting to the medication they're getting. Very important you get the nurse immediately. Or if you see the resident pull out or attempt to pull out their IV. So remember, we need 3 things to make a fire occur: heat, fuel, and oxygen. So, as nursing assistant Jade cares for a new resident, Mrs. Claiborne, she notices that Mrs. Claiborne has plugged a thin, frayed extension cord into the socket by her bedside table. She has plugged several devices and appliances into this very seemingly old extension cord. Mrs. Claiborne has been removing nail polish and left the bottle open with a damp cotton ball beside the bottle. Her roommate uses oxygen. So, what fire hazards are present and what should Jade do? Right? So, we said needs three things, right? Needs oxygen for a fire to start. Oxygen, right? It has it there. Needs to have a spark. That frayed extension cord that has too many things plugged into it very much can strike a spark, right? And then what's going to be that fuel? Nail polish remover is a big one, very flammable, right? So other potential causes of fire in facilities: smoking, frayed, damaged electrical cords. And once again, a lot of these individuals, because they're elderly, sometimes some of the lamps, electrical things they bring in are very old. Very important to check them, okay? Because some of these cords can get very broken down. All right. Anything like that, you can ask maintenance if they have something called a lockout tagout system. It's an actual device to go on the end of the plug so that that device is not used until it's repaired. Other things that can cause fires: electrical equipment in need of repair, overloaded electrical plugs, frayed cords, oxygen use, flammable liquids or rags with oils on them, stacks of newspaper or other clutter. Okay. So very important when she sees these hazards, okay, first things first, she should be cleaning up that nail polish remover and putting it away, right? Then following up with the nurse and seeing about getting, we can talk to maintenance, see about getting her a different extension cord and getting that one out of there. Then maybe a little education, right? Maybe Mrs. Claiborne didn't realize the dangers of having that frayed cord and nail polish remover out with her roommate and oxygen, right? And education is kind of a big thing that we nurses do. We got to keep people informed and we got to explain it to them in ways that they'll understand. So, another guidelines for fire prevention. Once again, if you are working in a facility where residents can smoke, you want to stay with them. There's ashtrays there. Check them. Make sure there's no lit cigarettes or matches. Put out burning cigarettes. Make sure the cigarettes or smoking materials do not fall anywhere, especially during the autumn season in New England. Leaf piles, very, very dry, easily flammable. You have to be careful with that. Make sure there are no hot ashes, matches, or cigarette butts in the ashtray before emptying it. Follow any policies regarding e-cigarettes and their batteries. Report unsafe electrical equipment and cords. And then report any smell of gas. And then it's going to be very important as nursing assistants that you know the location of fire alarms in your facility. Okay. And I will share one little story with you on smoking hazards. Okay. So I had actually gone to work at this point in my life. I had a roommate. They were a smoker. Okay. So we had outside of our place one of those tall plastic containers, has that wide base and then a skinny neck that comes up with two holes to put your cigarette butts in. Okay. So he had some friends over. They were entertaining themselves. I went to work. I come home and I go, where'd the cigarette container go? Well, him and his friends had gone outside. They had a cigarette. They put them in the receptacle and they forgot to make sure they were fully out. When I came home, that receptacle had already burnt into a mound of plastic that was attached to the pavement. And then there were some smoke marks next to my house. I am very lucky that our place did not go up in fire, right? But these are some of the smoking hazards people don't realize. And you can imagine My roommate got an earful from me about the fact he almost set our house on fire. Needless to say, we did not stay roommates for too much longer, right? But that's why you have to be careful. Make sure those cigarettes are out. They had changed it. It used to be back in the day that they would never stop burning. They now have paper that if it's not actively being inhaled, it should eventually go out. But still, be wary of that. Okay. Back in the day before it went out, I had an aunt, a great aunt. She was a smoker. She was at home alone. She was smoking a cigarette. She fell asleep. The cigarette fell on the floor. Back in the day, it's not going to stop burning. They didn't have that special paper. So it did cause a fire in the house. And unfortunately, in that fire, she did perish. Okay. So safety is very important when it comes to that. So we talked about that RACE acronym: rescue anyone in danger, activate the alarm or call 911. We're going to contain the fire by cutting off the oxygen source, by closing all doors and windows. And then we're not really going to extinguish, like I said, we're going to evacuate. We're going to keep us and the residents safe. PASS, we said how to use a fire extinguisher. We're going to pull the pin that's right under the handle, aim the hose at the base of the fire, squeeze that handle, and then do a sweeping motion back and forth at the base of the fire. Very important that you check your fire extinguisher for what it's used for. All right. Different fire extinguishers are coded for different types of fire, i.e., what started the fire. So some are for fires for oil, some wood paper products, some electrical. Make sure you're using the right one for the right type of fire. And it's labeled right on the side of the fire extinguisher. Okay. So some general procedures to follow in case of a fire. Know the location of your fire evacuation plan. Very important you remain calm, because if you're not calm, your residents aren't going to be calm. Remove all persons in the immediate area. Smoke goes up, so stay low in a room to escape a fire. Check closed doors for heat before opening them. If you are stuck in a room, smoke's coming out, you can use a wet towel at the base of the doorway to block the smoke from coming in. Use a damp covering. So if you can get to a sink, damp covering, even a shirt, get it in water. Use that over your face to help reduce smoke inhalation. And if you do on any part of you catches fire, stop, drop, and roll to put it out. In the event of a fire, you never want to get into an elevator. And if the facility allows it and you're evacuating, turn off oxygen and electrical equipment. Okay. Your main responsibility is going to be ensuring residents are removed to a safe place. So remember, living or working in a facility may sometimes put a person at risk of crime. Many people go in and out of a facility during the day, so it's best to watch for any suspicious behavior. If a nursing assistant notices any suspicious behavior, they should report it immediately. I have heard stories of people being so brazen that they've walked into a long-term care like they're there to visit, like they belong, and just as long as they presented themselves like they belonged, they've just wandered in and out of rooms, slowly pocketing and taking things while saying hi to the residents. And it took a bit before people realized, wait a second, we don't know this person, right? I have another story I can share with you. This was kind of scary. It happened when I was working overnight shift, 11 to 7, so bare bones staff. I had a call light, or should I say a ring, at my employee entrance door. This was the middle of the night, like 3 a.m. Somebody rings my employee entrance. Okay. I can answer through a monitor. I don't have to go to the door. So I say, hello. So a woman standing there. She says, hi, I am so sorry to bother you, but I just got into a car accident. My cell phone is dead. Can I please come in to call the police? Now, something in me said, a little suspicious, one. Two, I'm the only nurse in this building, and my job is to protect these residents, right? So I replied to her. I said, I am so sorry I can't let you in the building, but please stay right next to the door so I know you're safe, and let me call the police, and I'll have them here in a minute. I have them on the other line. Guess what she did? She immediately turned around and ran. So come to find out, There was a scam going around to local long-term care facilities. It was two individuals. One would go up to the door, and usually in the middle of the night, like 3 a.m., when they know there's not a lot of staff, okay, saying they're in a car accident. And then when the nurse goes to open the door, they unlock the door, the partner comes behind, and they both go in. Then they hold up the facility. They rob them of all their narcotics. So I am very lucky that I had a gut feeling and that I did not allow this woman in my facility, because we do in long-term care have a lot of narcotics. I got it all. The fentanyl, the morphine, a lot of different medications, narcotics these residents are on, especially end of life. Okay. So you got to be careful. Something feels off, trust your gut and report it. So, other steps that we can take to keep employees and residents safe. Remember, number one, we're going to report anything suspicious. If you have valuables, keep them at home. All right. I don't bring my purse out onto the nursing floor. Okay. Not that I don't trust my coworkers, but I want to be safe. I don't know who can get behind there. What if a resident's family member wanders behind the nurse's station desk? So I lock usually my purse in my trunk before I go in. Only thing coming in with me is my clipboard and my car keys that stay in my pocket. All right. Ask a nurse if a resident has valuables to lock them up. We don't want to keep them to keep anything too expensive in their rooms, in their drawers, because what can happen? Could be at risk of being stolen. If a visitor or staff member makes you uneasy, do not leave the resident alone with that person. Follow guidelines for number of visitors allowed in a resident's room. We're not going to share personal or confidential information with anyone. We're going to report any situation or person that makes us feel unsafe. And you've done it. Congratulations. You have made it through chapter 7, body mechanics. Like I said, very, very important chapter, because your job as CNAs is very physical. And the last thing I want is for you all to work so hard to get the certification, to get into the healthcare field, and then injure your back and have to leave. Okay. So make sure you're practicing, especially my very tall friends, good body mechanics. Okay. So I'm going to start pulling up the next PowerPoints. If anybody that is here, if you have a question, might make me a minute to notice, you are welcome to put it in the group chat as I'm lecturing, and I'll be happy to answer it for you. All right, got my slides up, so let me just share. All right, here we go. So we got chapter 8. This is going to be emergency care, first aid, and disaster. So as always, a lot of this you're going to talk about when you do your CPR certification, but we're going to talk about it a little bit too. Abdominal thrusts. So this is a method of attempting to remove an object from the airway of someone who is choking, sometimes called the Heimlich maneuver. There are going to be times where somebody is actively choking. Abdominal thrusts are going to be what's called contraindicated. So for instance, if it's a gentleman that's round enough around, you can't get your arms fully around him to do abdominal thrusts. Okay, you might have to use, say, a chair, have him lean over to apply those maneuvers. Okay, or even potentially come from the front. Pregnant women, heavily pregnant women, you can't necessarily do abdominal thrusts. So you have to do something more like chest thrusts to get it. Cardiac arrest is going to be the sudden stopping, or what we're going to call cessation of the heartbeat. If you see cessation from here on out, we do use that word a lot. That means to stop or arrest. A code team. So this is a group of people chosen for a particular shift to respond to residents' emergencies. Code teams are very common in the hospital. Basically, you will be given your role on that care team, be it grabbing the AED, starting chest compressions, be the one to initiate respirations, monitoring the pulse, whatever it is, okay? So when that code is called over the speaker, Code Blue, Room 101, Code Blue 101. It'll be your responsibility if you're a part of the code team to stop what you're doing, make sure someone can take over if you are in the middle of resident care, and respond to that emergency immediately. To be conscious is having awareness of our surroundings, sensations, thoughts. This is usually the first thing we check in an emergency, right? How are we going to learn CPR? You walk up, you want to touch them, shake them a little bit. Are you okay? Are you okay? We're checking for their level of consciousness. CPR. This is going to be that abbreviation for cardiopulmonary resuscitation. It is a medical procedure used when a person's heart and lungs have stopped working. Does anybody remember what it's called when somebody doesn't want CPR, the advanced directive? Did you say DNR? You are correct. If somebody has an advanced directive of a DNR, and once again, Massachusetts, it's on a form called a MOLST form, MOLST. You can look that up if you want to see what it looks like. Then you would not be performing CPR for those people. Okay. Otherwise, if they don't have that form, everybody is basically considered, unless they have it, a full code. So you pull out all the stops and start that CPR. Diabetic ketoacidosis. I already touched upon this a little bit in class when I was talking about that sweet smelling urine or sweet or fruity smelling breath. Okay. It's a life-threatening complication of diabetes. Can result from undiagnosed diabetes, an infection, not enough insulin, continued hyperglycemia, high blood sugar, eating too much, not getting enough exercise, and stress. Stress releases cortisol, which often makes us retain high blood sugar. Emesis. So emesis, I would say, is the polite word for vomiting, right? Or ejecting stomach contents through the mouth or nose. If you saw or will see in our lab room, we have a little kidney-shaped basin in there. Okay, we use the big bath basins. Little kidney-shaped one is called an emesis basin. Now, pretty small. Do you think it's going to hold much emesis? No. So if I have a resident who is sick, actively sick, I try and grab them a container for that emesis to go into. Sometimes it's the bath basin, sometimes it's the trash bucket, but I don't grab the emesis basin because it's just too small. It's not going to hold much. Only time you really see the emesis basin being used is when you're doing mouth care for the resident to spit into. Okay. So you don't see it too much, but very important. Any person that is vomiting, you get the nurse immediately. It is considered an emergent situation. Epistaxis is going to be a name for a nosebleed. So when somebody has a nosebleed, way I treat it, okay, first and foremost, I want them to lean forward a little bit, maybe tuck their chin down. Reason for that is if the blood is dripping down their throat, leaning back, it is more likely to go into their lungs. Having them lean forward, it is more likely to go into their stomach. Remember, these patients can be at risk of aspiration. So we much rather that blood drip into the stomach than the lungs, right? So I always have them lean a little bit forward. Then I do a nice pinch under the bridge of your nose. You feel that bridge bone right underneath? I do a solid, hard pinch. Okay. Hold that for a period of time. Then I let go. I very slowly take a tissue and I'll gently blot because I don't want to go like this, right? Dislodge any blood clot that's formed. It's going to start to bleed again. I'll gently go like this to see if it stopped bleeding. If it hasn't, I'll repeat the pinch. I'll do the pinch up to 3 times. Maybe at that point too, maybe get a little ice, never directly on the skin. Maybe put that a little bit over the nose to try and help slow down the bleeding. But if I can't get it under control at that point, I will send them to the emergency room. That point in the emergency room, they'll often either have the area cauterized or sometimes you'll see this balloon. And for lack of a better description, it almost kind of looks like a tampon. So it's this little balloon, goes up the nostril, they inflate it, puts pressure on that area, stops the bleeding. They'll later have to go back to their doctor to have it deflated and removed. So expressive aphasia, I talked a little bit about this in my day class. It's going to be difficulty communicating through speech or writing. Okay. Just so you know, someone has expressive aphasia doesn't mean they're still not a very intellectual person and that they don't understand you. They just have difficulty getting the words out to communicate back to you. First aid is going to be care given to an injured person by the first person that responds to an emergency. So, one thing, because I do have medical experience, I am a nurse, I will usually keep some sort of first aid medical supplies in my car. And when I drive by car accidents, I will slow down and watch. Is anybody there yet? Do they have a first responder on the team? Are police there yet? Because I would feel inclined to intervene if nobody was there yet and assist, since I do have medical knowledge. Hemiparesis. So let's break down that word, shall we? Hemi is going to mean half. So it's one half of the body. Paresis means weakness. Okay. Plegia means paralysis. So hemiparesis is going to be weakness on one side of the body. Hemiplegia is going to be paralysis on one side of the body. These are common signs and symptoms of a stroke. Okay. And then let's change that word. Instead of hemiplegia, let's change out hemi to quadriplegia. What do we think that means? Think quad, four, all four limbs. So someone with quadriplegia is going to be paralyzed usually from the neck down. They're not going to be able to control any of their limbs. So hemorrhage means bleeding or blood loss. Hyperglycemia. Remember, hyper, very common prefix, hyper, high, right? So hyperglycemia is going to mean high glucose, blood glucose or blood sugar. Hypo, remember that means low. Glycemia, this is low blood glucose or low blood sugar. Sometimes it's also known as insulin reaction or insulin shock. All right, both of these can be life-threatening emergencies. Myocardial infarction, MI. This is a heart attack. Okay, so when you hear myocardial infarction, heart attack. So it's a condition in which the blood flow to the heart is blocked and muscle cells die. Obstructed airway. So this is a condition in which the tube through which air enters the lungs is obstructed. An obstructive airway can be an indication why we're giving that Heimlich maneuver, right? Something gets stuck in their airway. Tall tale way to know if somebody's in a complete obstructed airway. Can anybody say what the universal choking sign is? Did you say this? You would be correct, right? So someone that has a complete obstruction, you're not going to see them going, oh, I'm fine. I'm choking. No, because you know why? If it's completely obstructed, they're not getting air into their lungs, which means they, one, can't cough, two, can't talk to you. That's when you need to intervene for the Heimlich maneuver. So they'll be making often the universal sign going like this, and it's going to be silent. They'll be doing this. Like they're trying to cough, trying to talk to you, but they can't. Also, sometimes you'll see them start to turn cyanotic with their face. Those are the times you'd want to intervene. Okay. Otherwise, if someone's coughing, even if it looks like they're going to pass out, I am one of those people, I'm very pale, right? So when I cough actively, my face turns into a bright tomato. Promise you, please don't do the Heimlich maneuver on me. I'm fine. Just let my body clear it. If somebody's actively coughing, let them clear it. Don't tell them to put up their hands. Don't whack them on the back. Okay. As long as they're actively coughing, they can talk, they're going to be okay. It's when they stop talking, stop coughing, that we have a problem, a real problem. So receptive aphasia is going to work opposite of expressive aphasia. So that means I don't understand you. I have difficulty understanding your spoken or written words. Respiratory arrest. So remember, arrest means to stop. So this is going to be the stopping or the sensation of breathing. Shock. This is a condition that occurs when there's a decreased blood flow to organs and tissues. Okay. Fear makes shock worse, and it is a life-threatening emergency. Syncope. Another name for syncope is fainting Fainting, it's a temporary loss of consciousness. So I will tell you one common occurrence where I do see syncope in my elderly. All right. For those that don't know, down in your perineal area, you have something called your vasovagal nerve. All right. So what often happens to my elderly is they are susceptible to getting constipated. So oftentimes I will see a CNA take a resident to the bathroom. They'll have a little bit of hard stool, constipation. So what are you going to do when it's hard? You're going to bear down to try and get it out. Well, when they go to bear down, they actually start to put pressure on that vasovagal nerve. When that happens, it causes a sudden drop in blood pressure. And this can sometimes lead to syncope. They'll be sitting on the toilet, you're keeping them safe, then all of a sudden they're going to faint on you. All right. Don't be too alarmed. Biggest thing about that is keeping them safe. If they faint, we don't want them to hurt themselves in the bathroom. Most of the time when I've responded to these emergencies, they come right back around. They're okay. They're safe. I calm my CNA down. I say, I promise they're okay. Their vital signs are okay. I've assessed them just a little bit, probably a little vasovagal nerve response there. Okay. And then if I find out, I'll ask them if you've been struggling to have bowel movement. Yes, I have. We'll go get them a stool softener to help that along so they don't have it happen again. All right. But I have seen it a few times in long-term care settings. Okay. So what is going to constitute a medical emergency? So one, if the person is unconscious, remember, as soon as we go on that scene, hello, are you okay? You okay? Two, if they're not breathing. Three, if there's no pulse. And then lastly, four, if they're bleeding or hemorrhaging severely. So when an emergency happens, very important we stay calm. Remember, if you're nervous and upset, everybody else around you is going to be upset. And then the other thing is you got to act quickly, communicate clearly. Okay. So anytime you're coming onto the scene of an emergency, very, very important. I want you to keep yourself safe. So you should always grab with you at least 2 pairs of gloves and another barrier device in the event of an emergency. Okay. You have no idea if that person's bleeding, what is in their blood. Okay. Or if they are bleeding. So make sure you're grabbing gloves on your way to hurrying over there. Okay. So ways, remember, being conscious is being aware of our surroundings, our sensations, our thoughts. Asking a person what happened, tapping them, right? Doing that little tap, tap. Asking if they're all right and seeing if they respond can help determine consciousness. So once again, we're in an emergency situation. First things first, make sure the area is safe. Okay, make sure it's safe. You're not going to be helping anybody if they're in an unsafe situation. Say this person was crossing the street, heavy traffic, and dropped. Please make sure you get out safety cones, get someone to redirect traffic. Okay, you don't want to put yourself as well in an unsafe situation because then there's going to be 2 people that are going to need help. So I can give you an example. I worked at a facility. It was the dead of winter. We had a bad nor'easter, and our entire parking lot was a sheet of ice. Maintenance had not gotten a chance to come around, lay down the salt. Okay. So we were trying to tell everybody, be careful going out there. CNA on another floor walks out the facility, isn't walking slowly. She needs to get home. What do you think happens? Boom, she goes down, hits her head, goes unconscious. Now, her nurse that was working upstairs with her was next to me and saw it. And she goes, oh no, says her name. Doesn't make sure the area is safe. What do you think she did? She ran right out after her to go see her, and boom, she goes down too. All right, now I'm staying late. We got 2 of my coworkers going out in an ambulance. All right, luckily, just so you know, the CNA was okay, mild concussion. She was back in a couple days. The nurse did aggravate an old back injury, so she was out for a couple weeks with that. All right. So just remember that nurse had good intentions. She wanted to make sure that CNA was okay. But once again, if you don't make sure that area is safe, then you just might be causing another person to need help. Okay. So first and foremost, make sure the area is safe. Second, put on gloves. Assess the situation. Notice the time. Time is very important when you're giving reports to the EMTs, paramedics when they get there, because time is of the essence and it tells them how long they have to do things, how at risk they are. Try to find out what happened, assess the victim, ask the injury or ill person what happened, determine if they're conscious, call for help or send someone to call for help right away. And if the person is conscious, listen to them. Reassure them that they are being taken care of. Okay. So when we're checking for an injury, we want to see, is there severe bleeding or hemorrhaging? Are there changes in consciousness? Are they coming in and out on you? They're responding to you and then kind of going out. Is breathing irregular? Is there an unusual color or feel to the skin? Swollen parts on their body? Big thing, medical alert tags. I know people that are so nervous that people aren't going to notice their medical alert tags that they've actually tattooed it onto like their chest, DNR, because they get worried about those things. All right. They want to make sure their wishes are respected or their medical treatment is given accurately, because there have been cases where people have been given CPR, brought back, and they were a DNR. Okay. They didn't realize they had that paperwork. So we got to be careful of medical tags. And then as always, any pain, you want to check for pain. So remember, a nursing assistant must document an emergency, complete an incident report as soon as it's over. Because as soon as it's over, it's fresh in your mind, you know everything that's happened, and you can remember as many details as possible. Remember, in our notes, we only want to report objective and subjective data. So the facts and what was told to us by the resident. Their pain would be subjective. Their recollection of the event would be subjective. Okay. So always going to be important to remember as many details as possible and to document it. Okay. Because the more information the nursing assistant can provide about the emergency, the more effectively the resident can be cared for by emergency responders. Facts rather than opinions are always best. Remember, it's beyond your scope of practice as nursing assistants to diagnose or make assumptions about what is wrong with the resident, even in emergency situations. So we do have an acronym. PPE-SCC can help nursing assistants remember how to perform first aid. So first and foremost, always, right? We want to protect ourselves, first and foremost. Self-care is not selfish, right? So PPE, grab and apply personal protective equipment, even if that's just gloves. Gloves, always, always. S is safety first. Are you safe? Or are you in the middle of traffic? Do you need safety cones? Do you need somebody to help redirect traffic or other people around the area? Call for help or point to a person and say, you get help now. And then lastly, last C is going to be, we're going to start caring for the victim. So very important, why time is of the essence. The first few minutes of an emergency can often determine the victim's ability to survive. Okay, so we do have some key terms in this learning objective to finish these sentences. So blank or the heart stopping can follow blank, which is when breathing stops. Do you remember what those two are? You did remember. Good job. Cardiac arrest and respiratory arrest, right? So when this happens to a person, blank is necessary to prevent or minimize brain damage. What's the name of the procedure we're performing in the case of cardiac and respiratory arrest? Did you say CPR? You are again correct. You're on game today. All right. Nursing assistants should never do anything beyond their ability or training. You're just going to give basic first aid until emergency medical team arrives. So what do we think? Another little self-reflecting questions. True or false? Residents who have difficulty chewing or swallowing or are confused or have poor vision may be at risk of choking. Yes, that's going to be 100% true, right? Any sort of difficulty chewing, swallowing that food can go down the wrong path. And we don't want it to go into the lungs, right? Because then they're at risk of aspiration and aspiration pneumonia. How about the next one? When something is blocking the tube through which food enters the digestive tract, the person has an obstructed airway. Did you catch the trick? I know you did, right? It's not. This is false because it's not the tube through which food enters the digestive tract, right? No, it's going to be the tube through which air enters the lungs. The person has an obstructed airway. So abdominal thrust should not be performed unless the person shows signs of severely obstructed airway. Okay, remember, severely obstructed. You're not going to hear them coughing. It's going to be silent coughing, trouble breathing. You're going to see signs of poor air exchange, cyanosis, and the inability to breathe or speak. And if you want to look in your textbooks on the procedure for performing abdominal thrust for a conscious person, it's on 134 of your textbooks. So residents had to be evacuated from Hartman Hills due to a fire in the kitchen. It is very hot outside where the residents are waiting. When nursing assistant Nadia is checking on residents, she finds that Miss Ortiz is sitting, just blankly staring straight ahead. She's pale, breathing rapidly. What might be happening to Miss Ortiz? I've had students give me a couple different examples, and you're not wrong, could be a couple things. But what I'm specifically looking for, what we talked about in our vocab words, is that she may be in shock. Remember, the symptoms of shock is going to be pale or cyanotic skin, kind of blankly staring. You're going to have an increased pulse and respirations. You're going to have a low blood pressure, and you might complain of extreme thirst. So shock occurs when organs and tissues in the bodies are not receiving adequate blood supply. Bleeding, heart attack, severe infection, and falling blood pressure can all lead to shock. Shock is a life-threatening situation, can be made worsened by fear or pain. And if you would like to see the procedure for responding to shock, it is on page 135 of your textbooks. So, why do we worry about bleeding? Why do we worry about hemorrhaging? Okay. Well, we got to think, what does blood do for us? Blood carries oxygen and nutrients to cells throughout the body, removes carbon dioxide and waste. So when we don't have enough blood circulation in the body, organs are not receiving the oxygen and nutrients they need to function. As well, in another consideration, your body works through something called homeostasis. Homeostasis is balance. So it's kind of what I give for an image of this. Think, anybody here, if you think about it, do you have a fish tank? Okay. Fish tanks often need filters. Okay. The water level needs to be at a certain level for that filter to work, right? What happens when you have a fish tank, the water level gets too low. The filter has a hard time functioning. That water level continues to get low, that filter can stop working. Same is going to happen with our heart when it comes to bleeding. Okay. Our heart, homeostasis, is used to a certain volume of blood. It knows with that amount what force to push it through the body to circulate. When that amount starts to deplete, it can cause the heart to struggle with knowing how to pump and circulate it. This can lead to an arrhythmia and lead to the heart stopping. Okay, so very important, severe bleeding can lead to death quickly, so it must be controlled. So if you come to a situation, severe bleeding, try and get a clean cloth, layer it up, firm, hard pressure down to stop the bleeding until help can arrive. Okay, so what are we going to do before we start severe bleeding? Yep, don't forget about your standard precautions, right? Put on gloves. put on gloves, okay? And if you want to see the procedure for controlling bleeding in your textbooks, it's page 135 to 136. So remember, if a resident is burned, remember we called that potentially scalds, we want to call or have someone call the nurse immediately. So there are different types of burns, okay? First degree burns are superficial burns. So for instance, you can all see I'm a bit of a very pale girl, okay? Some people have almost called me translucent before, okay? So because of this, because my skin is so fair, I cannot be in the sun for very long before I get burnt, okay? So if I am in direct sunlight for 10 minutes, that's all it takes for me, I get a bad sunburn. The sunburn is an example of a first degree or superficial burn, okay? What we're doing is we're taking the moisture out of our skin in this case. You need to put the moisture back in, okay? I got bottles and bottles of aloe vera all over my house for the summertime, okay? Second degree burns are more severe. They're partial thickness. So at this point, the integrity of the skin is going to be affected. So if I'm outside, I get a sunburn, I don't notice. I stay in the sun, direct sunlight for another 10, 15 minutes. I can actually get something now called sun poisoning. So now the burn has gotten to lower layers and my skin will actually bubble up and have fluid-filled blisters. So that would be an example of a second degree. Third degree burn is full thickness, okay? Oftentimes the skin can look charred, white, almost liquid. Very, very severe cases, they need to go. If you're at the point where you have third degree burn, that is, of course, an emergency situation right away, okay? Only time we can intervene or help is with usually just first degree burns, okay? Maybe the start of a second degree. The way we go about that is we can run that limb, if it's their limb that got burned, under cool water. We don't want cold, okay? Because we don't want to cut off circulation nutrients for that area to heal, okay? Cool. Very important, because think, when you're cooking in the oven and you take that food out of the oven, does it immediately stop cooking? No. Same with the burn. If we touch something hot and we remove our hand from it, our hand is still technically continuing to burn. So important to run it under that cool water to slow or stop that burn. And if you want to see the procedure for treating burns, it's on 136 of your textbooks. Okay. So remember we said syncope is another word for fainting. It occurs as a result of decreased blood flow to the brain, causing a loss of consciousness. Possible causes can be abnormal heart rhythm, hunger, low blood sugar. And remember, we called low blood sugar hypo or low glycemia. Fear, pain, fatigue can all lead to fainting. Standing for a long time, poor ventilation, pregnancy, and overheating. So there can be signs and symptoms that preclude the actual fainting. Person could start to complain of dizziness, nausea. They might start to perspire or sweat. My daughter's fainted before. I always can tell if she's about to because she goes even more pale than she already is. All right. Sometimes it's hard to tell pale skin in somebody who's already pale like me. So what you want to do if they are of a lighter skin tone, check their lips. Their lips lose all color. My lips will go as white as a ghost, and that's how you know I'm not feeling well. They can have a weak pulse, shallow respirations, and even complain of blackness in the visual field before they faint. And if you want to see the procedure to responding to fainting, it's 137 of your textbooks. Okay, so signs and symptoms, somebody might have been poisoned. They will be vomiting, could have heavy, difficult breathing, right? Dyspnea, difficulty breathing, remember? Could have drowsiness, confusion, and you might even see burns or red areas around their mouth from how caustic that substance might have been. So very important in these situations, whenever you suspect poisoning, you notify the nurse immediately and try and figure out what could they have ingested. Okay, so try and find the container. All right, after you find that container, you're going to go to your SDS sheets. All right, nurses calling 911. You're going to get those SDS sheets, see how toxic it is, see how to go about handling it, what you can do until help arrives. So remember, we said epistaxis is a nosebleed, can be caused by multiple different things. Dry air, oxygen is very drying. So if you have a lot of residents on oxygen, the air tends to be very dry. One way we can counteract that is we can put humidifiers on oxygen concentrators. And it kind of helps provide a little moisture to the oxygen. Only thing to be careful of with those, sometimes they're not the best. They kind of bubble over and we start to get water going through the tubing, which is not great. If that happens, let us know. We can blow out that tubing to get out any water, and maybe they just need a break from that humidifier or the water level in it is too high. If you are asked to put water in the humidifier, very important you use distilled water. Okay, should never just be tap water. Another reason people can get a nosebleed, medications. A lot of people are on blood thinners, Coumadin therapy. That's going to make them more susceptible to bleeding, and it's going to slow down their body's ability to clot quickly. And then last but not least, one more consideration, and I'll tell you a little story. I had a gentleman I was taking care of. Okay, he kept coming into my facility. He'd be in the bathroom, and when he'd come out, he'd scream, "Nurse, nurse." I'd go in. He had a nosebleed. He was on Coumadin therapy, so it was very hard to control it. Happened a few times in a row. Finally, I said, you know what? We can't figure out what's going on, what's causing it. I'm going to knock on that bathroom door before he calls me and see what's going on. All right. So I knocked on that door, opened it, said, "Hi, Mr. So-and-so, it's Carrie Ann. Can I come in?" "Yeah, sure." Opened the door, found out the reason. He was going for gold up there. He was picking it. That's why he kept getting nosebleeds. All right. So it can be injury. So we had to do a little education, sir, please don't pick your nose. If it's dry, there is some sort of, lubricants we can put in there to help with moisture issues. All right. But we don't want our people hurting themselves. But it explained a lot. Explained a lot. So if you want to see the procedure for responding to a nosebleed, it's on page 137 to 138 of your textbooks. So emesis is the act of ejecting stomach contents through the mouth or the nose. It asks what's the common term. I won't say it's the polite term because I think emesis sounds a lot more polite than the other one, right? So the other common term we're going to say is vomiting. Vomiting. Okay. So when somebody's sick, when they're throwing up, right, it's not a pleasant experience. It's very, very uncomfortable. So if the resident allows it while they're sick, stay with them. You can soothe them. Some people like to have their back rubbed. Okay. Vomiting may be a sign of illness or injury or reaction to a medication. So the nurse should know when a resident has vomited. And if you want to see the procedure for responding to vomiting, that's on 138 of your textbooks. Okay, so myocardial infarction. Remember, right? Myocardial infarction is a heart attack, right? Heart attack. So the signs and symptoms you're going to see, common ones, could be a sudden severe pain in the chest, pain or discomfort in other areas of the body, indigestion or heartburn, nausea or vomiting, shortness of breath, dizziness, lightheadedness, pale gray cyanotic or discolored skin color or mucous membranes. They could be perspiring, starting to sweat. Their skin might feel cold and clammy. When we check their vital signs, they're going to have a weak, irregular pulse. They're going to have a low blood pressure. They might state that they are having anxiety or a sense of doom, or they might start to deny that they even have a heart problem. So what do we think? Women may experience different MI symptoms than men. This is true. This is true. We got to be a little different, ladies. We got to be a little different. So we can have some more symptoms that don't look like a typical MI or heart attack. Okay. So for women, a lot of the times it can be just shortness of breath. Sometimes they'll get pain or pressure, but maybe not where the heart is. Maybe it's lower chest or even upper abdomen. They could complain of dizziness, lightheadedness, and fainting. Maybe that pressure they're feeling, they're actually saying it's in their upper back, or complaining of extreme fatigue. And then I actually had this to me with a woman who was having a heart attack. She actually just started to exhibit flu-like symptoms. Okay. So women, we can be a little particular about even our symptoms. All right. So Mrs. Jamil has diabetes. She has also had a virus that has caused diarrhea and vomiting. Nursing assistant Lane enters her room and finds that she is trembling, confused. She has a rapid pulse and low blood pressure. So looking at these symptoms, looking at her diagnosis, she's diabetic, what should she be going through? Did you say low blood sugar? You would be right. Remember, the name for low blood sugar is hypoglycemia. So hypoglycemia can be caused by too much insulin. In this case, it's going to be too little food, right? Diarrhea, it's all going straight through, or vomiting, it's all coming back up. Additional activity. So if people increase their activity, that can cause the body to rapidly absorb food. Of course, her symptoms, vomiting, diarrhea can cause hypoglycemia. Okay. So signs and symptoms: feeling weak or different, nervousness, dizziness, perspiration. They can complain of a headache, blurred vision, numbness of the lips and tongue. Their skin's going to feel cold and clammy. They're going to be trembling. They could complain of hunger. If I go to take their vital signs, they're usually going to have a rapid pulse and low blood pressure. They also could complain or you could see confusion and can lead to unconsciousness. Like I said, just like high levels of hyperglycemia can be an emergency situation. Think of our DKA, diabetic ketoacidosis, but so can low blood sugar. Remember, insulin shock. So anybody who's a diabetic, very important that they have some sort of source of ready glucose or sugar on them. Sometimes it's a hard candy. Sometimes we have at the nurses' stations, they're called their glucose tabs to help raise it. What people hear often is they'll give them juice, like an orange juice. Only thing I will say, as an overnight nurse, I have found the orange juice is high in sugar and is quick to raise the blood sugar. It's not going to maintain it. But the reason why your person has low blood sugar because of too much insulin, right? So overnight, I had somebody low blood sugar. If I give them a little bit of orange juice, I'm going to be chasing them all night. Okay. It's going to bring it up, but what's going to happen? Sugar drop. Now it's going to plummet back. Now I have to give more orange juice, and we're going to go like this all night. Okay. So good way to increase somebody's blood sugar and have it be maintained for a longer time is you want a fat, a protein, and a carb. All three are going to maintain those blood sugar betters. So if you remember, I talked the other day when we were talking about nutritional supplements for elderly individuals at risk of malnutrition. Ensures, Boost. I might give them a few sips of orange juice to bring it up quickly, right? But then I'll have them sip a little bit up on an Ensure or Boost. And that's going to help maintain them a little bit better so I can keep them at the facility through the night. Right? Because nobody wants to go to the emergency room in the middle of the night. I don't like sending my patients out unless I absolutely have to. Because chances are they're going to be sitting in that hospital room for a while, right? And going to be sent back. So if I can stabilize them at my facility till the doctors come in the morning, I'm going to do that. All right. Like I said, overnight nurses often have a little phrase, t-shirt, keeping them alive till 7:05. So remember, these signs and symptoms mean that the resident needs food. Diabetic residents should always have a quick source of sugar handy. So other condition I talked about, DKA, diabetic ketoacidosis, could be caused by undiagnosed diabetes, infection, not enough insulin, hyperglycemia, remember high blood sugar, eating too much, not getting enough exercise, and then physical and emotional stress can add to it. So remember, DKA can lead to diabetic coma and death if left untreated. So you should know the signs and symptoms of it. So what it's going to look like, they're going to have increased hunger, thirst. They're going to be peeing, urinating a lot. They could complain of abdominal pain. They could have difficulty breathing or deep breathing, something called Kussmaul breaths, Kussmaul. And this is deep, rapid breathing that almost kind of sounds like this. All right? Like they can't get enough air in their lungs. Their breath might smell sweet or fruity, almost like you can smell the sugar in their body. They could complain of a headache, blurred vision, dry skin, dry mouth. They could have flushed cheeks, nausea, vomiting, loss of appetite. They're going to have a rapid, weak pulse, and they're going to have low blood pressure. They could have shortness of breath, that air hunger, weakness, drowsiness, confusion, and of course, it can lead to unconsciousness. So I have students ask me in the past, they said, well, Carrie Ann, some of the symptoms of hyperglycemia are the same as hypoglycemia. How is a nurse going to know a difference? Well, that's why we have little machines, little blood glucose machines. So when somebody's exhibiting these symptoms, first thing I do, I'm going to check their blood sugar and see what it reads. Okay, and that's going to let me know, is this hypoglycemia, hyperglycemia? But there are some signs and symptoms that are different too, right? But they're just a lot that parallel or overlap, should I say. So nursing assistant Austin enters Mrs. Loeb's room, finds her shaking severely. Her jaw is clenched and her arms and legs are moving uncontrollably. Now, this hasn't been one of our vocab words. We haven't talked about it yet, but what do you think is likely to be happening to Mrs. Loeb? And what should Austin's main goal be in caring for her? Okay, so clenching of the jaw, involuntary movements. This is likely that Mrs. Loeb is having a seizure. Okay, main goal in a seizure, you are not going to try to move them, restrain them. You are just going to make sure she stays safe, okay, while she's actively seizing. So that's removing things around her that could cause her injury while she is actively moving uncontrollably. Okay, so you want to review these signs of a seizure. There's severe shaking, uncontrolled thrusting of the arms and legs. You can see clenching of the jaw, sometimes drooling. There's going to be an inability to swallow. So many different things can cause seizures. Could be abnormality in the brain. High fever can lead to seizures. Serious illness, head injury. And then some people just have seizure disorders, or a seizure disorder is a part of another medical condition they have. Okay. And if you want to read the procedure for responding to a seizure, it's on page 141 of your textbooks. And just to make you aware, there are different types of seizures. Sometimes it's more evident somebody's having a seizure. Sometimes you have more mild seizures where honestly you don't recognize someone's having one. They just kind of sit and go blank for a second. Okay. Mini seizures can be difficult to spot. So remember, a cerebrovascular accident, CVA, is the name for a stroke. It occurs when blood supply to a portion of the brain is cut off. So there's going to be two types of stroke: ischemic, so that's going to be caused by a clot or a blockage. Then you have a hemorrhagic stroke, so that's going to be caused by a rupturing of the blood vessel. Okay, TIA, this stands for transient ischemic attack. Okay, it's transient ischemic attack. Sometimes it's nicknamed mini stroke. Okay, but it's basically a warning sign of a stroke. TIA, the symptoms are going to be very similar to a stroke, but what ends up happening is it reverses. So we think they're having a stroke, and then all of a sudden they go back to normal. So it's a warning sign that they're at risk for a stroke. Okay. So signs and symptoms you might see could be facial numbness, weakness, or drooping, especially on one side. Paralysis on one side of the body. Remember, we called that hemiplegia. Arm or leg numbness or weakness, especially on one side of the body, hemiparesis. Trouble walking, loss of balance. They could have slurred speech or inability to speak, which is expressive aphasia. They could have an inability to understand spoken or written words. We called this receptive aphasia. They could use inappropriate words that might not make sense all of a sudden. They might start complaining of a severe headache, blurred vision, or trouble seeing out of one or both eyes. They might have ringing in the ear, redness to their face, noisy breathing. If I take this person's vital signs, they're going to have a slow pulse rate and an elevated blood pressure. They can also have nausea or vomiting, could result in a loss of bowel or bladder control. So they'll have an incontinent episode, can turn into a seizure. They can complain of dizziness and can even have a loss of consciousness. So very, very important when anybody is starting to exhibit any of these signs and symptoms, you report it right away. There is a medication, a clot busting medication, that has a very high success rate of reversing the signs and symptoms of the stroke in the case of an ischemic stroke, but only if it is administered within 4 hours of the onset of symptoms. Just got a question. Where does the adage of smelling burning coming from? What causes this symptom? Or is it the reason it's a symptom of a CVA? Can be it's a symptom of a CVA. And to be honest, I'm not quite sure what causes them to kind of smell that burning. But yes, that's an interesting symptom that they can have as well. All right. So once again, with the stroke, ischemic stroke, very important. You report those signs and symptoms right away. They do have clot busting medication that they can administer if given within 4 hours of the onset of symptoms. So that's why time is of the essence. All right. Unfortunately, hemorrhagic strokes caused by a rupturing of a blood vessel, have a less likely success rate because it's only a couple things you can do. One, if it's minimal, let the area heal on its own. Or two, go in surgically to stop the bleeding. Okay. And unfortunately, sometimes if that blood vessel that ruptured is in a spot, might be inoperable. So unfortunately, this happened to one of my uncles. He was in his 50s, just happened 2 years ago, where he had a hemorrhagic stroke. They brought him to the emergency room. He was flight lifted down to Boston Medical. Fortunately, that bleed was near his, I'm sorry, to the back of his vein. I'm forgetting a basic word again. Anyway, it was near his nerve, so it was inoperable. Brainstem. There we go. Sometimes I forget basic words. So it's actually near his brainstem, and it was inoperable. So unfortunately, my uncle did pass. Okay. So just like we need to be a little unique and difficult with heart attacks, we're going to be unique with strokes as well. So sometimes women can have different symptoms. These can actually be, they'll complain of pain in the face, arm, and legs. They'll hiccup. That's a funny symptom, right? But I've actually seen it. Shortness of breath, palpitations, chest pain. They could get agitated, hallucinate, or become disoriented. So FAST, an acronym we used when responding to potentially a stroke to see if they are having one. So F is going to stand for face. Look at their face. Ask them to smile. If you ask them to smile and one side goes up and the other side doesn't, that's indicative of a stroke. The smile's uneven. Arms. Are the arms numb, weak? Ask them to raise both arms. If one arm isn't coming up at the same level as the other one, could be a sign of a CVA. Ask them to speak. Is their speech slurred? Can you understand them? Can they repeat a simple sentence? Is the sentence correct? And then once again, the last is going to be time. Time is always of the utmost importance when responding to a stroke. Report it to the nurse immediately. Okay. Rapid treatment can limit damage from a stroke. So if you decide to work in a hospital, you're a member of the code team. Okay. You may be asked to get special equipment like the AED. You may do chest compressions. It's important to remember you must respond to codes for wherever you are in the facility. Don't panic, all right? And get another staff member to take over any care you're performing. So remember, a disaster can occur at any time, including during a nursing assistant shift. I will let you know, and knock on wood, I have never had to deal with many natural disasters in New England. Haven't gotten, unless you're on the East Coast, you're not, or on the waterfront, oceanfront, you're not really going to have to worry about flood. We don't get earthquakes, a hurricane, or tornadoes too much. What you really have to worry about around here is our nor'easters, our winter storms. Okay. Acts of terrorism, also considered disasters. Important to note, nursing assistants are expected to respond calmly and skillfully to disasters. Need to be responsible and efficient. I will tell you this, remember, you are essential workers, right? It's not like if it's snowing, you can just stay home from the office and do the paperwork tomorrow, right? You're caring for people, they need you. So plan accordingly if you know a snowstorm's coming in, right? Get up early, make sure you can wipe down your car so that you can go slowly heading into work. I've had it before I had to go in, and the storm was so bad that they were telling everybody to stay home except essential workers. So it was like I was driving and the streets aren't plowed very well. So I'm going very, very slow in my SUV. And I was constantly having police officers stop me. Ma'am, you need to go home. And I constantly have to say, sorry, sir, I'm going to work. I'm a nurse. Finally, I just had one gentleman. He followed me into work just to make sure I was safe because the roads were so bad. So prepare appropriately, okay? You're still an essential worker. You're still needed. Don't be that person that every time there's a few flurries falling down, you call out, okay? Because once again, that work, people still need to be cared for. You're just putting it on somebody else. I've also worked in assisted living facilities that were very nice. So when they had extra rooms where they didn't have residents, they would actually let the staff stay the night at the facility. So that way they could go to work tomorrow and they didn't have to work about commuting home and back in the snowstorm. So you can see if they offer that option. So do a little time of reflection. Have you ever had any experience with disasters? If yes, what actions did you or others do that were helpful? Which ones weren't so helpful? All right, so guidelines for the event of a disaster. One, you want to always know your facility's disaster plan, and you should be going over that during orientation. You want to pay close attention during classes or disasters and disaster drills. Listen carefully, follow instructions, remain calm. Remember, be the behavior you want to see. If you look anxious, guarantee everybody around you is going to be anxious, right? I remember when I was pregnant with my firstborn, okay, I thought my water had broke. I was leaking some fluid. So I said, oh, my water must have broken. Called the doctor and they said, well, if that's the case, your contractions are going to start soon. Okay. Well, my contractions didn't start. I was like, what's going on? So the next day they say, okay, go to the hospital. I went to the hospital. Okay. And they talked to me and I said, yeah, I'm just leaking a little bit. Happened the last few days. And they said, oh, well, you're getting bigger. The pressure of the baby might just be a little bit of stress incontinence. Okay. We'll do a test, make sure it's not amniotic fluid, and then we'll discharge you and send you on your way. So I had this nurse come in. She had the discharge paperwork in her hand. Okay. And she said, hi, I have it. Let me just test the strip real quick. Make sure because it was a strip to test the pH. Okay, to know if the fluid coming out of me was urine or amniotic fluid. Okay, so she's happy, pleasant to me. Hi, here you go. Here's your paperwork. Let me just pick up here, let me take that paperwork. Just stay right here. Stay right here. And she runs out of the room. You can imagine as a 21-year-old woman pregnant with my first child, I was like, what's the matter? Well, it was amniotic fluid. So I had to be induced and put on an antibiotic because I had been leaking that amniotic fluid for a few days, right? But I didn't need to be stressed like that as a young mom, right? So make sure you're aware, not only in disasters, but other things, your poker face, okay? If you look stressed, your patients are going to be stressed. Okay? And that's the end of that chapter. All right. Like I said, if you're watching this video after it's been recorded, if you have any questions, feel free, because I know it's not interactive if you're not with me, write them down, send them to me via email or text. If you are here, once again, I'll always answer if you put in the group chat. All right. So we got a little bit more time. I'm just going to do one more chapter and then I'll let you all enjoy your weekends. Okay. Cool. Okay. This one is relatively short. Share. It's going to be chapter 9. It is admission, transfer, discharge, and physical exams. So I will tell you while we're doing this chapter, we are going to talk about different positions. These are not the positions that you are going to put residents in on a daily basis in, say, a long-term care setting. Okay, we'll get more into those when we get into additional chapters of bed making. Okay, these are more positions that you might, if you're working with a doctor who's doing a physical exam or a nurse doing a physical exam. All right, so don't stress too much about understanding or knowing these positions. But when we get to bed making, repositioning a resident, you are going to want to know those ones. Okay. So as always, we start with our vocabulary words. So your admission pack. These are personal care items supplied upon a resident's admission. A lot of the times, if they have a rehab unit or short stay unit, they'll make these ahead of time because they get, sometimes 3-4 admissions in a day. Okay, but otherwise, just think it's going to be all your ADL supplies. So you're going to get your wash basin, emesis basin, toothbrush, toothpaste, deodorant, razor, okay, soap. To admit, that's the entrance of a person to a healthcare facility. So we're beginning care. Baseline. So if you guys remember, I've been talking about baseline a lot, and I've been saying, what's that person's normal? Baseline is very important because when we get to the vital signs chapter, I'm going to teach you all the normal range of a blood pressure, the normal range of a pulse. But in all honesty, I don't worry about normal range as much as I worry about someone differing from their baseline. Okay, I'll give you an example. My husband, it's just genetic. All the men in his family are tall, slender, and they have high blood pressure. Okay, it's just hereditary, not lifestyle choices. It is what it is. As soon as they're born, all the gentlemen have high blood pressure. Okay, so my husband's baseline, his normal, if you take it, is 140 over like 92. Now, once we learn normal range for a blood pressure, you're going to see that that's considered hypertensive, okay, or high. But for him, that's actually normal. Okay, it's his normal. So say you are working with my husband, you go in and you take his blood pressure. You get 100 over 62. Well, 100 over 62 is considered within normal range. But when we compare it to his baseline, remember his baseline's 140 over 92, what are we going to think? Something's wrong. His blood pressure should not have dropped that much. Maybe he has a hemorrhaging somewhere. Something's going on, right? But if we just worried about normal range, we might not be alert to the problem. So that's why I care more about someone's baseline than I do normal range. Okay. If someone's bedridden, we're going to say they're confined to bed. When we discharge somebody, they're released from that healthcare facility. It's ending care. Remember, discharges are voluntary. When they're involuntary, that's an eviction. All right, we're getting into our first position, dorsal recumbent. And don't worry, if you are like me and you're a visual learner, I am going to show you a slide so that you'll see an image of it. Okay. But just know this is a position where somebody's flat on their back, their knees are flexed and slightly separated, and their feet are flat on the bed. So kind of think of the position you would get someone in if you were about to have them lift their butt to put a bedpan under them. Okay. You'd want their legs a little bent, right? That would be dorsal recumbent. The kilogram. The kilogram is a unit of mass equal to 1,000 grams. 1 kilogram equals 2.2 pounds. Depending on what facility you work is how they record residents' weights. They'll either be in pounds or kilograms, and you can just ask them which way they prefer. Okay? And then just know the conversion if you have to convert, right? So if somebody is 50 kilograms, you times 2.2 to get their weight in pounds. And then vice versa. If somebody's 150 pounds, you divide by 2.2 to get their weight in kilograms. The knee chest position. This is a position in which a person is lying on their abdomen with knees pulled towards their abdomen and legs separated. Arms are pulled up, kind of over their head and flexed, and the head is turned to one side. And once again, it's okay if this isn't making sense to you, because I'm going to have some images for you to help. Okay. So lithotomy, all the ladies, I'm sure, are familiar with this position. This is the position we get in with any GYN OB visits. Okay. So it's when we're lying on an exam table and we're positioned with on our back. Our hips are moved all the way down to the edge of the exam table, and our legs are flexed and our feet are in those padded stirrups. Metric. Metric is a system of weights and measures based upon the metric and the kilogram. A pound. So a pound of weight is equal to 16 ounces. You will not need to know this conversion for our tests at Royal Healthcare, but you will need to know one thing. So I'm giving you one of the test questions, all right? And I know this seems silly, but I want to make sure you know because it's a test question. How many inches are in a foot? Silly question, but they ask it. 12. 12 inches in a foot. Think the length of a ruler if you're not aware. Okay. So make sure, wink, wink, test question, you get that one. So when somebody returns, we say they're going to have a readmittance of a resident to a care facility. So maybe they had pneumonia, went to the hospital, came to us to recover. They did good, went home. Then all of a sudden they suffered a fall at home, had a hip fracture, went to the hospital. They could be returned to our facility for rehab again. And then when we transfer somebody, we're moving a person from one place to another. It's going to be a formal handoff of care from one healthcare professional to another. This can be within the same facility. So maybe they're moving from the rehab to long-term care. Okay. And then it can also be to other facilities. So they're transferring home, not home to another healthcare professional, but maybe transferring to a hospice house, back to their assisted living. Okay. Maybe they're just transferring rooms. So remember, choosing the right facility for a loved one can be challenging, can be emotional. It's a difficult process. Nobody, as they're young, looks and says, yeah, I really want to go to a nursing home when I get old, right? Nobody says that. Nobody gets excited about it, okay? So it's usually last-ditch effort. Nobody wants to leave their home. And the geriatric population we're taking care of is very independent, very proud, very dignified. So it's a very hard process for them to go through when they have to decide on a facility to live at. So if you are looking at a facility for your grandparent or parent, you're going to want to ask some questions, make some observations. Very important to do a visit. Okay. Do the staff seem courteous and friendly? Do most of the staff speak the resident's native language if your loved one doesn't speak English? Or do they have an interpreter available? Are there enough staff members on duty at the facility? What's the ratio of nurses and nursing assistants to residents? How is the facility staffed on evenings and weekends? Some assisted living facilities actually don't have nurses on staff on overnight and weekends. So if you're worried about your mom having, more medical care on hand in case of an emergencies, that might not be the spot for you. You're going to want to ask those questions. Are there foul odors present? Remember, I don't care if I smell stool. Nobody's poop smells like roses, right? But I care if I smell a strong sense of urine, because I'm going to question whether they're changing their incontinent paper for it to smell like that, or cleaning their devices that collect urine, such as bedpans and catheters and the graduate containers if I'm smelling urine. What's the food like at the facility? That's the question I'm going to be asking. What are you feeding me? What variety do you have? Okay. I'm a food focused individual. Is attention paid to individual food preferences, right? So if you have a special diet, are they going to respect that based on cultural or religious needs? Is a dietitian available for meeting? Do staff interact positively with residents? Does staff speak courteously to other staff members? Look at the residents. Are they well groomed, taken care of, happy? Or do you see them disheveled in dressing gowns with a blanket barely covering them, sitting facing a wall in the hallway? Unfortunately, I have seen that, where people have treated residents like a conveyor line. All right. How are the residents' complaints resolved? Is the facility licensed? Check out their state survey results. Remember, those are public knowledge. You should be able to ask and access them and look at them. Does the facility explain residents' rights? Are there physical, occupational, or speech therapists on site? Or do you have to go out for those appointments? How often do falls, infections, pressure areas occur? And sometimes you can see those stats in the state survey, and they can give you a good idea of how well care is going. Do they have volunteers come in? If so, are they interactive? One thing I really love about Duville, they have a lot of volunteers, and it's wonderful to see. How involved can the family be in creating the resident's care plan? Does the facility provide the level of care the resident needs? What about future needs? Is the environment safe, functional, home-like, right? Does it feel sterile, or does it feel nice? Biggest thing I always say that helps with it feeling home-like, windows. Oh, you need windows, natural light, fresh air, does wonders. All right. If you haven't heard of her, look up Florence Nightingale. She was all about sunlight, fresh air, and she did wonderful for the nursing professions. What are the steps to take if a resident wants to move out of the facility? All right. What's the expense? I saw a couple months ago an article about a family who was very, very upset. They had had their loved one in this facility. The loved one passed away, and they were charged for the next month. Well, it turns out that was in the contract, that if their loved one passes, they still have to get charged for some reason for an additional month. They were very upset about that. So make sure you learn what the procedure is for that if finances are an issue for your family or a consideration. What policies does the facility have on advance directives? End-of-life decisions. Do they provide end-of-life care there? Can hospice workers come in there? Okay. So moving into a facility is a very big adjustment. New residents may have been independent for a long time, and they may be moving from their own or a family member's home. It's a time of loss and many strong emotions. So remember, you're not going to get to know their true personality right off the bat. They're going through a time of grief, a time of adjustment. Give it at least 3 to 4 weeks before you really see their personality. And then I talked to a student the other night who was saying, I have somebody who still can't accept that they're there, and it's been 3 years, right? So sometimes that happens. Just try and be comforting, reassuring, make them feel like they're not just moving into the facility to die, they're moving to have a new family that's going to care for them and make sure they're loved and safe until that time naturally comes. Okay, I'm going to skip that slide. So what are some of the losses residents may experience when they're moving into a facility? Okay, move may have been sudden due to health reasons, so it's a bit of a shock. Residents may have had to leave their home, give up personal belongings. You're going to see those teeny tiny rooms. There's not a lot of space to put things. I'm looking around me. This is my office. I have art supplies everywhere. Okay. I couldn't fit half of my art supplies, let alone anything else in those residents' rooms. Right. So it's a lot. They have to give up a lot to get there. And that's why you respect those personal belongings. They're either highly sentimental or highly important. Okay. They've also maybe had to give up their beloved pets. Most long-term care places do not allow animals. Some assisted livings do, but it all depends on it. Residents may have had loved ones who had died. Residents may be experiencing a decline in health and independence. So always going to be important that we empathize with residents to help make their adjustment to the facility life easier. Sensitivity will make this change easier. Remember, we always want to encourage them to get involved in activities, encourage them to meet new residents, but we're never going to force them, right? Just helpful little nudges, Okay. So how do you think a nursing assistant can help new residents adjust to life at long-term care? Well, first and foremost, be the attitude you want to see. So be positive, be tactful, okay? If you give them a time for something, stick to it. Let them know that you are trustworthy. Communicate clearly. Show respect for their belongings. Be responsible. Be honest. Listen to residents. Pay attention to their wishes. Respect residents' privacy. Be patient and kind. So remember, admission is often the first time a nursing assistant meets a new resident. When the resident arrives, the nursing assistant has the opportunity to give a good first impression of the staff in the facility. So you want to welcome the new resident in a friendly manner. Okay? Let them feel welcomed. Let them know that they're just not going to be treated like an object. They're going to be treated like a person. And even more important, like their family. So we're going to use some key terms from the learning objective to finish these sentences. Residents who come to live in a long-term care facility are blank or allowed entry. So what's another name for allowing entry in a healthcare facility? Admitted. Some residents may have lived at the facility before. So if they're coming back, we call that, yes, a return. Nursing assistants often prepare blank with essential items such as toothpaste, soap, tissue. So what did we call that when we give them their kind of essential ADL supplies? Admission pack. They also may be given the job of taking blank measurements. These are the most important, kind of their normal, that are going to be compared to future measurements. We call this their baseline. Okay. So when we are admitting a resident, we have certain steps to take. If you want to follow along in your textbooks, this is going to be on page 150 to 151. So first and foremost, we're going to wash our hands, gather necessary equipment to bring to the resident's room. We're going to prepare the resident's room before they arrive. We're going to make the bed, open curtains or blinds. Introduce yourself. Call them by their formal name unless they give you permission to state otherwise. That's why I usually start the conversation as, what would you like to be called? So then we don't have to go through. Because some people are like, hi, Mrs. Smith. And they're like, Mrs. Smith, that was my mother. I'm not Mrs. Smith. All right. So that's why I always ask, what would you like to be called? All right. Then I don't have to make assumptions. They can just let me know. Don't rush the process. Introduce the new resident to their roommate and maybe some other residents that are in the same functioning level. So if you're admitting somebody that's more high functioning, still very social, then I'm going to want to introduce her to the other people that are too, that she can get along with, have a good conversation with. You're going to explain the day-to-day life in the facility. Show residents how to work the bed controls. All right. Show them how to use the call light. Big thing, show them how the television works. Okay. Residents struggle all the time. Somebody's not calling for water or to go to the bathroom. Usually it's they're calling because they can't get their controller to work. All right. And their phone, help them with their phone. Handle personal items always with care and respect. So true or false, a kilogram is a metric unit of mass that equals 2.2 pounds. Yep, you got it. True. So when I am admitting a resident, I do take their weight and their height. Here's the thing. Not really worried about height, okay? You gradually lose height as you age, okay? You lose some of your cartilage between your vertebrae, causes your height to gradually decrease a little bit, so I'm not worried about that. What I am worried about, okay, and that I monitor a lot more often besides admission, routinely, it's once a week, okay? Or some people, it's daily, is their weights, okay? Weight very much can be an indication of a change in a resident's health status. Okay. And if you want to see the procedure for measuring and recording weight on an ambulatory resident, that's 152 of your textbook. Bedridden resident, it's 153. Okay. We also have mechanical lifts, Hoyer lifts over at Deauville. They're wonderful. They take weight. So as I Hoyer somebody with the lift, it will read their weight on a screen. So ask to see that. If the regular staff are Hoyering somebody when you do clinical, pardon me, ask to see where the weight reads. Okay. And like I said, changes in height are not as likely to indicate changes in a resident's health. Height may decrease gradually with age, but changes do not indicate illness as changes in weight may. Okay. And if you want to see measuring and recording height in an ambulatory resident, it's 154 of your textbooks. If you want to see measuring and recording height of a bedridden resident, wink, wink, might be a question on maybe a midterm, maybe a final. That's 154 to 155. Important to note, just because someone's bedridden doesn't mean we can't take their height, right? We have these little things we lose a lot in the nursing world called tape measures, right? We use tape measures to not only measure wounds, okay, but we also can do for height. So as that person's lying in bed, we'd run this down the full length of their body from their head to their feet to get their height. Okay, so if you see, wink, wink, test question, okay, that says, how do you get the height on a bedbound resident? Okay, the answer is not, it's never possible. Okay, you can do it with the tape measure. So remember, transfers can be difficult for residents. Remember, transfers are when we're changing position. So from the bed to the wheelchair, or from sitting to standing and walking. Nursing assistants can help by trying to make these moves as smooth as possible. And also using good body mechanics, right? Keeping them nice and close to you. That resident is going to feel a lot more secure when I transfer her with my arms around her in a hug than if I hold her all the way out here, right? So remember these points about transfers. You're always going, and that's transfer as in moving somebody. But I think this one's relating, and I'm sorry if I got a little confused for you. Transfers as in moving their home. So if they're going to another healthcare facility. So the resident should be informed if they're going to another healthcare facility as soon as possible. Nursing assistant should pack the resident's personal items carefully. Nursing assistant should know the method of transfer and the plan to move. So are they walking? Is it a wheelchair? Is it a stretcher? Is the family coming and they're getting in a personal vehicle? Are they using wheelchair van services or an ambulance? The nursing assistant should introduce the resident to everybody on the new unit. And when leaving the room, I know this should go without saying, but you'd be surprised. Nursing assistant should report to the nurse in charge of the resident. Let them know they're there. I cannot tell you how many times I've been working and I've been busy, and someone has brought a new admission in, put them in the room. EMTs, paramedics have done this to me, even family. Bring them to the room they're going to be at, and then just walk out. All right. Then an hour later, we see a call light. Why is a call light going off in an empty room? And there's that lady. I've been waiting an hour for someone to come in and talk to me. Right? We do not want that. If somebody's getting admitted to my facility, they're under my care. They're under my license. I want to know. So please make sure everybody knows that the new admission is there. Okay. And if you want to see the procedure for transferring a resident to a new room, that's on page 156 of your textbooks. So remember, a discharge is official after the doctor writes the discharge order that releases the resident to leave. So like anything nurses do, we are bound. We need doctor's orders for everything. So remember these nursing assistant responsibilities during discharge of a resident. You're going to collect the resident's belongings, pack them carefully, be positive and reassuring. Know if the resident will need a wheelchair or a stretcher. Okay. So one of the things we say is that a resident is still our responsibility, even when they have that signed doctor's order, okay, until they are in the car with the vehicle door closed. Wink, wink. Might see this on a test question. In the car with the vehicle door closed, all right? Because it's important to emphasize that resident is still a resident, okay? So say you're outside the building helping them walk to the vehicle, they fall. Are you going to say, "Oh, sorry, mom, come get her because she's not my patient anymore"? No, right? You're going to get her up. You're going to be bringing her back in. You're going to be caring for her, okay? So she's still the nursing assistant's responsibility until that vehicle door is closed, okay? And if you want to see the procedure for discharging a resident, that's 157 of your textbooks. So remember, physical exams can be embarrassing, uncomfortable. Part of a nursing assistant's role, okay, most of the time is going to be like just helping the resident, keeping them safe, keeping them positioned well, listening to them, talking to them, holding their hand. So the physician or nurse might ask you to go grab them some equipment, might be the blood pressure cuff. If you haven't learned yet, this is a mouthful, so don't worry about it. But the official medical name for a blood pressure cuff, if you don't know, is called sphygmomanometer. All right, if you want to see the spelling, it is in your textbooks, but it's called sphygmomanometer. Sphygmomanometer. Okay, so they might ask you to grab it, but I guarantee you they won't say that. They'll say, get the BP cuff. Right? They're going to need alcohol wipes, stethoscope, flashlight, maybe a thermometer, tongue depressor. They're doing eye chart, vision checks. They might need an eye chart, a tuning fork, a reflex hammer, otoscope. Remember, that's an instrument that looks into the ears. Ophthalmoscope. This is going to be an object that shines light and looks into the eyes. Okay, you have the resident kind of look away, and it's a way to try and visualize their retinas. Specimen containers might need lubricants, something called a hemo-occult card, and we'll get into that in the GI chapter, but it basically checks for hidden blood in the stool. Might need a vaginal speculum. Okay, so for gentlemen in the class, might not know this, it's an actual device that goes into the vaginal canal, opens it up so the physician can view the cervix. Gloves and drapes, they might not all need. So as promised, I know we're getting to the end of this chapter, but I promised you a visual of these positions. So here they are, okay? See the top dorsal recumbent? That's the position we got somebody in when we were putting them on a bedpan, have their legs kind of bent so they can lift their hips to get that bedpan under them. Lithotomy, think of GYN-OB gynecology. So that's the position we often get in for those exams. And then knee chest. Kind of see, it's kind of like almost like a reverse kind of fetal position, kind of, except being on your side, you're on your stomach, and those knees are separated out a little bit. Okay. And like I said, are you yourself ever putting any of these residents in these positions in long-term care? No. All right. So they're not as well known. But if you decide to help at a doctor's office, working in a hospital setting, ER, you might see these more often. So in addition to gathering equipment, reassuring the resident, helping with positioning, other things you may be expected to do. Okay, so we're just going to go over guidelines for assisting. First and foremost, you're going to wash your hands before and after the exam. You're going to follow standard precautions. We're going to collect, label specimens as needed, provide privacy measures. We're going to listen to and reassure the resident. We're going to follow doctors and nursing instructions. Make sure the resident does not fall. Remember, safety is key, right? You might just be the one providing a light for the doctor or nurse. If it's a sterile procedure, remember, very important, you don't break sterile fields. So you might be putting instruments in their proper place and handing them to the doctor or nurse to assist them. And then at the end, when they've had the exam, you're going to help the resident get cleaned up and dressed. You're going to dispose of trash, and you're going to bring equipment to proper area. If a specimen was taken, you're going to have to make sure it's labeled. Resident's name, new room number, time and date it was collected, and then transport the specimens as needed. Okay, some specimens can be refrigerated, picked up in the morning by the lab tech. Others need to be sent out immediately to the lab. So ask the nurse for clarification for what that is. Okay. All right. And you've done it. You've gone through 3 chapters today. I'm very proud of you all for having the patience to do that. Okay, so if you can this weekend, after watching the video, try and do these 3 chapters in your workbook. Okay, remember, you don't want those questions to snowball on you. So try and do in your workbook chapters 7, 8, and 9. Remember, you also don't have to do the crosswords. I'm not a huge fan of those, but I do expect you to complete all the other questions. All right. Otherwise, thank you all so much for watching my video. I appreciate you all you students, and I hope you have a wonderful 4th of July weekend. Remember, healthcare is only going to work for you and prevent you from caregiver burnout if you have good work-life balance. So take this time to enjoy yourselves and your families, and I'll see you all bright-eyed and bushy-tailed on Monday. All right? Have a good one, everyone.